Good morning and welcome to today's New York City Council hybrid hearing on the Committee on Health, jointly with the Committee on Hospitals. At this time, please silence all electronic devices. Thank you. For those of you who may be viewing on Zoom, if you wish to submit testimony, you may do so at testimony@council.nyc.gov. I repeat, testimony@council.nyc.gov. Thank you for your kind cooperation. Chair, we are ready to begin.
Good morning, everyone. I am Councilmember Lynn Schulman, Chair of the Committee on Health. I'd like to start by thanking the co-chair of this hearing, Councilmember Narcisse, for joining me for this important discussion. I also thank my colleagues for being present today. We've been joined by Council members Menon, Hudson, Gutierrez, Brooks Powers, and Areola. Today we'll be discussing maternal health, mortality, and morbidity. Last Friday, while I was in a briefing with Chair Narcisse discussing this hearing, the Supreme Court issued an opinion to overturn Roe v. Wade, thereby reversing nearly 50 years of precedent and ending the federal constitutional right to abortion. As a result of this decision, half of U.S. states are expected to ban abortion. This decision will literally have deadly consequences that will unfortunately fall hardest on Black women and birthing people who already face a severe maternal mortality crisis. Our country has a long history of discrimination and structural inequality that is deep-seated within the healthcare system. This decision will only exacerbate this, with forced pregnancy policies disproportionately affecting people of color, immigrants, LGBTQIA+ individuals, young people, and those who are poor. Because of the Supreme Court's decision, our right to control our own bodies and futures will unfortunately depend on our economic status and where we live. For folks who live in states that outlaw abortion, New York will become a safe haven. And while New York has more progressive laws protecting a woman's right to an abortion, we must continue to do work to improve maternal health outcomes. That is what we're here to discuss today. The ability to protect the health of mothers, birthing people, and babies in childbirth is a basic measure of a society's development. However, more people in the United States die of pregnancy-related complications than in any other developed country. And while the number of reported pregnancy-related deaths has been declining in most of the world, in the United States, the maternal mortality ratio has increased compared to similar countries. Across the United States and in New York City, maternal mortality disproportionately impacts Black women and birthing people, with Black people 8 to 12 times more likely to die when giving birth than their white counterparts. Research points to race rather than educational attainment or income level of the patient as the cause of such discrepancies. This is not a new discovery. We have now known for many years that Black women and birthing people face disproportionate rates of maternal mortality and morbidity, and yet little progress has been made. Today, I hope to hear from the administration and our hospitals about how they are working to ensure that we track relevant data and outcomes, make assessments and reflect on healthcare decisions, and understand and train on how bias and discrimination play a role in the delivery of healthcare. Because at the end of the day, everyone, regardless of what zip code you live in or who you are, should receive good healthcare. And we need to work together to make that a reality. We will also be discussing a package of legislation related to maternal health, mortality, and morbidity. This includes introduction number 508, which I am proud to sponsor, which would require the city to establish a family building benefit for city employees intended to cover some or all of the costs of assisted reproduction and adoption for city employees without conditioning reimbursement on an infertility diagnosis. In implementing such benefits, the city would be prohibited from discriminating on the basis of marital or partnership status. I also want to thank my colleagues for introducing other important legislation, and we look forward to discussing your bills today. I look forward to examining all these crucial issues. I want to thank the administration for being here this morning. I also want to thank all of the advocates who have been working tirelessly to improve birthing outcomes in our city. Thank you to the doulas and midwives, many of whom I worked with when I worked at Woodhull Hospital in Brooklyn, for your work as well, and being strong advocates for your patients and for being a very important part of this dialogue. I also want to thank the committee staff for their work on this issue. Assistant Deputy Director Sarah Liss, Committee Counsel Harbani Ahuja, Policy Analyst M. Balkin, as well as my amazing team, especially my Chief of Staff, Fascia Class. I also want to thank Kevin and Javier, who are two staff members who are here today with me. Sadly, this is M's last hearing with us at the council, as they'll be moving on to pursue further studies. I want to say a huge thank you to M for all their work over the last 4 years on the Health Committee. You have had an enormous impact on the council's work in making the city healthier and more equitable, and you will be truly missed. Thank you again, and we know you will go on to do more amazing work. And I also want to, on a personal note, say that I worked with M when I was a member of the Speaker's staff a while back, and they are amazing. On that note, I will turn it over to my wonderful co-chair for today's hearing, Chair Narcisse, for her opening remarks.
Good morning, everyone. I'm Council Member Mercedes Narcisse, Chair of Committee on Hospitals. I would like to start by thanking the co-chair of this hearing, Council Member Shulman, for this important discussion. I also thank my colleagues for being present today. Today, we will discuss maternal health, mortality, and morbidity. This is a topic I care greatly about, especially after having spent my career as a nurse. Hundreds of years of race-based medicine, coupled with systemic racism and other forms of oppressions, have led to stark disparate health outcomes faced by communities of color like myself, and in particular, Black, Indigenous, and Hispanic birthing people. To reiterate some of the figures already shared by my colleagues, Chair Shulman, maternal mortality disproportionately impact women of color and birthing people, with Black people 8 to 12 times more likely to die when giving birth than their white counterpart in New York City. Studies have shown that regardless of educational attainment and income, Black women and birthing people are still more likely to die from childbirth than white people. The fact that Black women and birthing people are not receiving the care and resources they need to survive during childbirth is inexcusable and morally reprehensible. Despite decades of work by advocates calling attention to these extremely important issues, as well as years of council hearings and action on this topic, I'm here today because there remains more to be done. I'm also here today to remind everyone that the field of gynecology itself is rooted in racism, and of course, most of us probably remember that, and was only advanced because of the abuse of enslaved Black women. After public outcry in response to the murders of George Floyd, Ahmaud Arbery, Breonna Taylor, and others, over 18 organizations signed a collective action statement against racism in the field of obstetrics and gynecology. A portion of the statement acknowledged many examples of foundational advances in the specialty of obstetrics and gynecology are rooted in racism and oppression. For example, the mid-1800s, surgical experimentation of James Marion Sims was preferred on enslaved Black women, including 3 women, Bessie, Lucy, and Anaka, who underwent repetitive gynecology procedure without consent, and I believe without anesthesiologists being there too. This historical content further highlights how deeply these injuries run and how rooted healthcare is in race-based medicine and racism. This hearing, which is taking place in the month of June, not too long after Juneteenth and after the painful overturning of Roe versus Wade, 50 years, we'll examine how the city continues to strive to provide meaningful and equitable care for birthing people, particularly birthing people of color. I thank Chair Schulman for already having discussed the impact of recent Supreme Court decision. We all know, I'm sorry, this is very emotional, yes. We all know that the dismantling of Roe versus Wade will disproportionately impact poor people, people in the South and conservative states, and Black other birthing people of color, the same people we should be striving to protect. High quality reproductive and maternal health care should be accessible across the board, and this decision has sadly and tragically set us apart. Yet, we must continue to fight. We are also discussing a package of important legislation touching upon issues ranging from access to doulas and midwives to proliferation of information regarding the risk of C-sections. This includes Resolution 201, 2022, which I am proud to sponsor, which calls on New York State to establish full insurance coverage for fertility treatment and fertility cuts across socioeconomic, racial, ethnic, and religious lines. Cost is the #1 barrier to seeking family building assistance, as 46% of affected people lack insurance coverage for treatment of infertility. This is unacceptable. Today, we must center ourselves on the purpose of the work, improving maternal health, including maternal health outcome and fertility. We must honor and remember those who have lost due to pregnancy-related causes, of which CDC states that 2/3 are preventable. We remember them today, including those who may not have been reported in the press. We are also mindful of all those still with us today who nearly died during giving birth. I'm also mindful that given the Roe versus Wade decision, more and more people will be at risk when accessing care and giving birth in this country. I'm sincerely grateful for the advocates, doulas, midwives, and other birthing professionals who have been working to address maternal mortality and morbidity for years. We cannot task you with fixing this crisis alone. You have my commitment as a partner in this work. And I look forward to hearing from you and continue to work together. I want to thank the administration for being here today and for their tireless work since the pandemic began. I also want to thank Chair Schulman again, as well as the members of Hospitals Committee and the Health Committee for joining. I also thank the committee staff for their work on this issue. Committee Counsel Habani Hahuja, Policy Analyst M. Balkan, as well as my amazing staff, including Saya Joseph, Frank Shea, and all my staff. As Chair Schulman mentioned, this is M's last hearing with us. M, you know, we appreciate you. I want to say a huge thank you to you for all the work you have done. You have been such a wealth of knowledge, and I appreciate all the work that you have done for this committee over the years. You are a brilliant and wonderful person, and you will be surely missed. We wish you so much success in your future and hope our paths cross again. Thank you. And for some that may wonder why I'm so emotional, I've been a nurse for 3 decades. I have heard so many that cannot have children today because of where they had done the abortion. For some, it's a religious or moral. Like I tell everyone, I'm not the higher power since most of us have faith. I'm not here to judge no one, but we have the responsibility to do the right thing, especially for those that's underprivileged that we call in high-risk area. My district, 46th district, right now we took the brunt of this pandemic. We don't have no hospital, no community health centers nearby for many. And we're not doing preventive care. And now we have Roe versus Wade overturned. So thank you, and I appreciate your time. I will return it now to my co-chair hearing, Chair Shulman.
Thank you for those amazing remarks, Chair Narcisse. I want to acknowledge we've been joined by Council Members Rivera, Joseph, Velasquez, and Gutierrez. And I also want to hand it over to Councilmember Menon for her statement.
Thank you so much. I first of all want to thank Chair Shulman and Chair Narcisse for today's very important joint hearing. Last Friday, we heard devastating and horrific news with the Supreme Court striking down Roe v. Wade. To think that my daughter and every single daughter across this country has less rights than we had is absolutely unconscionable. For women without abortion access, they need hope and they need our help. Our message is clear. New York will stand firm to once again be a safe haven for people who need access to abortion. Among the bills before the committee today is my legislation, intro number 490, which would create an Office of Sexual and Reproductive Health within the Department of Health and Mental Hygiene. The intention of the bill is to prepare our city for increased demand for abortion and related reproductive needs. The office would have three main goals. First, it would provide outreach, education, and support on sexual and reproductive health, particularly for low-income individuals and people without health insurance. Second, it would make referrals to affordable and accessible services. And finally, it would conduct research on sexual and reproductive health disparities across the city. Establishing this office would ensure that the city remains vigilant and proactive in helping New Yorkers access services, testing, treatment, screenings, and health education. According to the Center for Disease Control and Prevention, the number of abortions reported in New York City was 49,784 in 2019. Notably, 4,668 out-of-state individuals sought out abortions. Since these numbers will surely grow higher, this bill will refer women to affordable and accessible providers. In addition, this office would also be responsible for analyzing disparities in access for sexual and reproductive services. Not everyone can equally access reproductive services. Income, neighborhood, and health insurance are all major determinants for the quality of services requested. Traveling to New York City requires a lot of funds, particularly for people with few resources. Meanwhile, New York City should be prepared for states that limit travel for abortion. This new office can be a resource to help alleviate any burdens for people traveling. Lastly, the office would also study disparities across our city. The Center for Reproductive Rights found that Black and Indigenous women are nearly 3 times more likely to die from pregnancy-related complications than white women. This must change, and an Office of Sexual and Reproductive Health can lower this disparity. I thank the chairs for allowing me to speak, and I look forward to today's hearing.
Thank you, Councilmember. Now I'm going to hand it over to Councilmember Hudson for her statement.
Thank you, and good morning. I'd first like to thank Chairs Shulman and Narcisse for holding this important hearing today on maternal health, mortality, and morbidity. I'd like to briefly speak on my bill, Introduction 478. Introduction 478, co-prime, sponsored by Councilmember Jennifer Gutierrez, would require Department of Health and Mental Hygiene to conduct an education and outreach campaign about the services offered by doulas and midwives, to increase awareness of efforts to improve access to such services, and share information about free and low-cost resources related to such services. It would also require DOHMH to submit a report describing the methods of outreach used to comply with this section. As we know, Black folks are the most at risk of mortality and morbidity issues when giving birth and controlling for income, education, and other factors. Studies show that Black women are more likely than their white counterparts to give birth at hospitals with high rates of maternal morbidity and up to 12 times more likely to die from pregnancy-related issues than white women. And Black women are more likely to die from conditions like hemorrhages and preeclampsia. Simply put, this is an issue of racism and implicit racial bias. My home borough of Brooklyn has the highest number of pregnancy-associated and pregnancy-related deaths. One clear way to reduce this gap is to provide doula access to more people. Studies show that a vast majority of women report that a doula helped them feel more empowered to speak up for their needs and better communicate them. This bill, coupled with my colleague Councilmember Gutierrez's bill to create a pilot program to train doulas and provide no-cost doula services across the city, will help reduce the maternal health disparity by increasing access and awareness of doulas and midwives. I urge the Committee on Health to swiftly pass these bills and the Council to pass them so all Black folks giving birth can have an advocate for their health standing by their side the entire way. Thank you.
Thank you, Councilmember Hudson. Now I'm going to ask the committee council to swear in the administration.
Thank you, Chair. Members of the administration, if you could please raise your right hands. Do you affirm to tell the truth, the whole truth, and nothing but the truth in your testimony before this committee and to respond honestly to council member questions? Thank you. When you begin, just please state your name for the record. Thank you.
Good morning, Chair Shulman and Narcisse and members of the committees. I am Dr. Michelle Morse, Chief Medical Officer and Deputy Commissioner for the Center for Health Equity and Community Wellness at the New York City Health Department. And I'm joined here today by my colleagues, Laura Lewison, Assistant Commissioner, Dr. Tara Stein, Medical Director, both from the department's Bureau of Maternal, Infant, and Reproductive Health. I'm also joined by our colleague, Dr. Michelle Allen, Chief Medical Officer at New York City Health and Hospitals, Dan Pollack, First Deputy Commissioner, and Claire Levitt, Deputy Commissioner from the Mayor's Office of Labor Relations. On behalf of the administration, we thank you for the opportunity to speak today on the important issue of maternal health, sexual health, and birth equity. We want to first acknowledge the Supreme Court's decision to overturn Roe v. Wade, and with it, the U.S. constitutional right to a safe abortion, a right that was in place for half a century, and the profound and devastating impact this will have on health in this country. The city is committed to ensure all people have access to the appropriate resources to make an informed decision about their body. We plan to address abortion access in detail at the reproductive health hearing later this week. Maternal mortality is a grave and urgent issue with persistent racial and ethnic inequities in our nation, and New York City is unfortunately no exception. Although we have seen a statistically significant decline in the maternal mortality rate since 2001 in New York City, unacceptable inequities among racial and ethnic groups remain. In New York City, the average maternal mortality rate among Black pregnant people is more than 9 times the rate of white pregnant people. Our review of pregnancy-related deaths indicates that the vast majority of these deaths of Black people were preventable. The borough that accounted for the most pregnancy-associated deaths was Brooklyn, followed by the Bronx. Before proceeding further, I want to acknowledge the heartbreaking injustice and human impact represented in these statistics. As a practicing physician myself, I know that every person who dies during childbirth is a parent, a sibling, a child, a friend, a community member, and that their sudden and tragic absence from the lives of their loved ones, and in many cases their newborns, is unacceptable. Every loss is a profound tragedy with ripple effects in our communities. When a mother dies, no community is ever the same. We're compelled to action as a city to address this crisis and reduce preventable birth-related deaths and eliminate the unacceptable injustices that these deaths represent. Birth inequities are driven by racism and bias in government, in medicine, in education, in housing, and in economic policies, amongst many others. And the downstream effects of these intersecting systems of oppression will take years and even generations to undo. Differential access to power and resources has created these health inequities, and it requires the investment of resources and deliberate corrective actions to repair. It requires a true anti-racism approach. Our work is grounded in data with a focus on outcomes among Black and Latina people who are pregnant or may become pregnant. We use that data to drive and design the programs, strategies, and policies that will support individuals' access to the supports they need for healthy pregnancies, reproductive health, and parenting. We support families through the New Family Home Visit Initiative, a range of linked home visiting programs, including the Nurse Family Partnership, Newborn Home Visiting, Citywide Doula Initiative, and the By My Side Birth Support Program. We support programs that support systems change in partnership with hospitals, clinicians, and community-based organizations throughout New York City, including the Maternal Mortality, Morbidity, and Review Committee, the Maternity Hospital Quality Improvement Network, the New York City Breastfeeding Hospital Collaborative, Centering Pregnancy, Centering Parenting, By My Side Birth Support Program, our Midwifery Initiative, and our department's Birth Equity Working Group. I'd like to share a little bit more about some of these initiatives that are relevant to our conversation today. In 2018, the Health Department established the New York City Maternal Morbidity and Mortality Review Committee, referred to as the MMRC. The committee meets monthly to conduct a multidisciplinary expert review of each maternal death in New York City from both clinical and social determinants of health perspectives. The MMRC has 31 diverse multidisciplinary members from all 5 boroughs and includes community activists, doulas, midwives, nurses, specialists, case managers, public health workers, and others. At the end of every calendar year, the committee reviews and decides upon key recommendations which, if enacted, would improve the care of pregnant people. We then publish these in an annual report. The goal of the MMRC is to reduce preventable maternal deaths by gaining a holistic understanding of each maternal death to determine the cause, assess preventability, and identify contributing factors, actionable recommendations to prevent future tragedies. The committee's recommendations address systems, facility, provider, and patient-level factors. Another flagship initiative from the Health Department is the newly expanded New Family Home Visit Initiative, which expands access to home visiting programs and community resources to an estimated additional 22,000 newly eligible families. The New Family Home Visit Initiative offers a range of evidence-based home visiting services through trained healthcare workers and clinical providers, such as social workers, nurses, and lactation consultants. This includes breastfeeding support, creating a safe home, mental health screenings, and connections to social services. This initiative has been supported by the expansion of the Newborn Home Visiting Program, the Nurse Family Partnership, Power of Two, and the Citywide Doula Initiative. The program is open to first-time families in the Task Force for Racial Inclusion and Equity, also known as TREE, neighborhoods. Also those who live in NYCHA in TREE neighborhoods and those who are engaged with child welfare. I want to highlight our Nurse Family Partnership Program, which is one of the home visiting programs included in the New Family Home Visit Initiative. NFP is a long-standing, evidence-based home visiting program that connects first-time expectant parents with trained nurses to promote healthy pregnancy outcomes, child development, and economic independence. New mothers who participate in the NFP experience lower rates of hypertension, decreases in tobacco use, and lowered risk of preterm birth. The department has also long acknowledged and embraced the role of doulas in improving maternal health and birth equity, and several council members have already referenced doula initiatives. The expanded Citywide Doula Initiative that was just launched provides doula support both at home and in the clinical setting with 3 prenatal visits, support during labor and delivery, and 4 postpartum visits. Clients who give birth at home receive the same number of visits. This program includes screening and referrals for family needs and stressors such as food insecurity. The Citywide Doula Initiative ensures that the model of care is consistent across our city and that uniform data is collected for a rigorous evaluation of the doula services provided through this initiative. We also know by evidence and research that doulas lead to fewer cesarean sections, healthier birth weights, lower rates of depression, and increased rates of breastfeeding, as well as, perhaps most importantly, increased satisfaction amongst the people who receive their care. The Health Department has developed a series of public awareness campaigns to promote citywide understanding of healthy pregnancies, reproductive health, and parenting. To gain community input on these campaigns, we conducted listening sessions with community members, as well as focus groups with healthcare providers. These campaigns include Safe and Respectful Care, aimed at community residents and healthcare providers to educate New Yorkers about their rights and options before, during, and after pregnancy, and to promote the standards for respectful care. This is just a sample of some of the programs and work, all of which demonstrate our fierce commitment to this issue. We must hold all levels of government and healthcare accountable to make health equity a reality for all New Yorkers. That is precisely what the city is trying to do. The work we do at the health department is grounded in science, equity, and compassion. We are committed to focusing on improving the overall health of New Yorkers and on ending racial and ethnic inequities in health outcomes. We envision a world where all New Yorkers live healthy, fulfilling sexual and reproductive lives, where all children are born healthy, nurtured, and loved, and where all births are safe. And we're committed to making that vision a reality. Turning to the legislation being heard today, the bills in this package cover a wide range of protections for pregnant people and those who may become pregnant. We are grateful to Council for bringing further attention to these critical issues. The city supports the intent of Introductions 86, 409, 472, 478, 482, 490, 508, and 509, and we look forward to discussing the specifics with Council after the hearing. Introduction 86 would require the Health Department to educate about city standards for healthcare proxy forms, patient rights, and respectful care at birth. We support the intent of this bill. As mentioned earlier, the Health Department develops standards for respectful care at birth through careful engagement with community stakeholders. We currently provide education about the standards at birth facilities and in other facilities used by people of reproductive age. We believe this bill would be most impactful as a joint strategy to provide reproductive health resources in multiple languages that are safe and accessible for New Yorkers. Introduction 409 would require the department to post an annual summary of vital statistics regarding maternal mortality in New York City on its website, and we're pleased to report that these reports are online under our special report section on our New York City Health Department website. Introduction 472 establishes a pilot program to train doulas and provide doula services to residents in all 5 boroughs. We're pleased to report that the department does run a citywide doula initiative, and that was detailed in my earlier testimony. We look forward to discussing this program with Council. Introduction 478 would require the Health Department to provide outreach and education on the benefits and services provided by doulas and midwives. We are aligned with the intent of this bill. In fact, the Health Department supports a funded outreach and education campaign for doulas and midwives. Currently, the Health Department's Citywide Doula Initiative has an outreach and education campaign in 3 neighborhoods showing the benefits of doula services and offers a paid doula apprenticeship for local community residents. Introduction 482 requires the department to report on polycystic ovarian syndrome and endometriosis. We have operational concerns with this bill as the department lacks a feasible mechanism to collect this data. We're eager to discuss the bill further with you after the hearing to better understand the intent and work with you to meet your goals to address these and other related women's health issues. And Introduction 490 codifies an Office of Sexual and Reproductive Health within the Health Department. Fortunately, our Bureau of Maternal, Infant, and Reproductive Health exists within the Health Department's organizational structure, and we're pleased to have the opportunity to talk about some of our work with you today at this hearing. Our teams undertake tireless and often unsung work for New Yorkers every day, and we really appreciate your time today to share some of this information. We look forward to working with Council in partnership on this topic, and my colleagues and I are happy to take our questions. Thank you.
Thank you very much. Before we do questions, Councilmember Gutierrez would like to make a statement.
Thank you, Chair Shulman and Narcisse. Doulas and midwives are critical for improving maternal health outcomes. When women use doulas during pregnancy and birth, they are 2 times less likely to have birth complications and 4 times less likely to have a low birth weight baby. The World Health Organization recommends that every birthing person should have access to a doula. They have a very special skill set. I was lucky enough to have a positive birth experience with a midwife and a doula that resulted in a healthy baby and my own well-being, but for too many, this is not the common experience. Currently, the program is limited to 6 zip codes and 8 vendors, hoping to reach 500 people by the end of June. There are about 17,000 births per month in New York City. We need to start the expansion of this program yesterday, which means we need more doulas in the pipeline now. I do appreciate the mayor's attention to this issue and his plans to expand on the current program, but the state of maternal mortality is a crisis that must be addressed as soon as possible. Women are going to keep having babies every day, and that's not slowing down to wait for a program's expansion or the funding to come through. In 2017, there were 58 deaths associated with pregnancy. 40% of the deaths were Black women and 28 were Latina. 28% were in Brooklyn and 21% in Queens. Just 9% were in Manhattan. Black New Yorkers are more than twice as likely than white New Yorkers to have severe complications in childbirth and 8 times more likely to die from pregnancy-related causes. Doulas and midwives are a known solution to this problem. They are ancestral, they are indigenous, and they are not new or innovative ones. The bills introduced by my colleagues make important steps to increase the visibility of life-saving birthing options and access to data on maternal mortality and morbidity. These bills are vital steps towards understanding the crisis we have in our city, towards teaching people what their options are. I am certainly excited to support them and see them through. I'm also proud to have my bill heard today and ensure that not only women have more support during birth, but also that we can create well-paying employment opportunities in the caregiving space, and especially for women of color, to support their communities. Thank you.
Thank you, Councilmember Gutierrez. I'm going to turn to OLR, Office of Labor Relations, to give you a testimony.
No problem. Thank you, Council Member. Good morning, Chair Schulman and Chair Narcisse, and members of the committees. As my colleague mentioned, my name is Daniel Pollack. I'm the first Deputy Commissioner at the Office of Labor Relations, and I'm here with my colleague, Claire Levitt, the Deputy Commissioner for Healthcare Strategy at the Office of Labor Relations. Thank you for the opportunity to testify today. We're here to discuss Intro 508, which would require the city to establish family building benefits for city employees intended to cover some or all of the costs of assisted reproduction and adoption for city employees. Before going into the specifics of the current and proposed benefits, we want to provide some brief background for context. As you may be aware, since 1967, the city has been obligated under the New York State Public Employees Fair Employment Act, commonly known as the Taylor Law, to bargain health benefits with its municipal unions. The benefits that are the subject of Intro 508, like other health benefits and fringe benefits, are mandatory subjects of collective bargaining under the Taylor Law. This means the city must negotiate these matters with its unions, and these benefits cannot be imposed by local law. Experience has also shown that the city and its unions, working together, can and do negotiate significant improvements in employee benefits, including health benefits. I now would like to take the opportunity to summarize our current relevant benefits related to fertility. For context, the city spends over $11 billion a year on its health benefits for employees, dependents. I apologize. I'll take it off. All right. I apologize. Would you like me to go back at all? All right. As I mentioned, the city spends over $11 billion a year currently for health benefits for employees, dependents, and retirees. To put the enormity of that expense into context, it's over 10% of the city budget of $101 billion. In accordance with state requirements, the New York City Health Benefit Program covers the following benefits related to infertility: intrauterine insemination, known as IUI, 3 cycles of in vitro fertilization, IVF, medication, including prescription drugs and injectable medications, egg preservation, where the patient is undergoing treatment like chemotherapy that would affect the viability of the eggs. Additionally, through our primary employee health plan, the city utilizes WIN Fertility, an organization that supports families with infertility issues. WIN Fertility helps families navigate the system with nurse case managers that ensure that the highest clinical standards are met. We believe that our fertility benefits are very strong, and we currently spend over $100 million a year on fertility benefits for city employees. Our fertility benefits, like all of our health benefits, are limited to city employees and their dependents. For example, we cover IVF, in vitro fertilization, for people covered by the health plan, not for surrogates who are neither employees nor dependents. As we understand, this is the case for practically every other employer-provided health insurance. Moreover, as recent State Department of Financial Services guidance explains, while New York insurance law was amended in 2019 to ensure that existing coverage was afforded for individuals who are unable to conceive due to their sexual orientation or gender identity, the amended change did not address surrogacy arrangements or require coverage for services that are not otherwise mandated to be covered under the insurance law. The Office of Labor Relations strongly believes that all city employees deserve high quality and equitable health care. As we have for many years, we will continue to work with our municipal unions to make appropriate modifications and enhancements to our health plan in the best interest of employees and taxpayers. Thank you for the opportunity to testify, and we'll be happy to answer any questions you might have. Thank you.
Thank you very much. Could we also get a copy of your testimony as well?
Yes, I believe I provided it earlier to the Sergeant at Arms.
Oh, okay. Thank you. All right, so I'm going to start asking some questions, and then I'll turn it over to my chair, and we'll have some of my colleagues who also will be asking questions. So the first one I'm going to ask is, how will the overturning, move this for a minute. How will the overturning of Roe v. Wade impact maternal health, mortality, and morbidity? Shall we expect more people coming to New York City to receive maternal health care? Whoever wants to take it.
Thank you, Chairperson, for that really important question. We are very concerned about the impact that the overturn of Roe v. Wade will have on access to abortion care across the country. However, we really want to reiterate that in New York City, abortion is legal, and we are very concerned, however, that there will be impacts on people of color and people who are poor, in particular in states where abortion is not legal. I'm going to pass to my colleague, Laura Lewison, to share some additional comments.
Thank you, Dr. Morse. I want to reiterate what Dr. Morse said, that abortion is still legal in New York, and we do anticipate that there will be increased demand for abortion services following this decision. The Health Department is working actively with our national and local partners, including our colleagues at Health and Hospitals, other private healthcare facilities in the city, advocates, and community-based organizations to prepare for this, and we've been preparing for this since the leaked opinion. We are working to protect existing access, and we're excited to stand with the mayor in his announcement to ensure that New Yorkers and those who travel to our state can access abortion care by providing accurate information to the public and to providers and supporting expansion of services in collaboration with clinicians.
How can we ensure that we provide safe, equitable, and sufficient care to those in need from other states? Because I think that what's being planned is that there's going to be a great influx.
Thank you, Councilmember. You're correct. We do anticipate that there will be an influx. It's hard to calculate what the actual numbers will be, but we have been actively preparing for that for the past 2 months. I want to reiterate again that it is safe and legal in New York, and we also know that not all New Yorkers right now can easily access abortion services currently. And so to ensure access for both New Yorkers and for those who travel to our city as a safe haven, we have to ensure that people have accurate information about how and when to access care and how to pay for that care. All people need to be able to obtain abortion, regardless of their ability to pay for services or to pay for the associated costs with receiving an abortion, like childcare or transportation.
How are we going to get information to them? Are we going to work with the hotel industry if people are going to come here, stay there, or are people going to stay with relatives and friends and all that? How are we going to get that information out there to people?
That's a great question. And we anticipate that people will probably pursue a number of different strategies. We're working closely with community-based organizations and advocates to better understand the landscape of what that travel might look like on a national level and also within our state. And we are also working right now on a communications campaign to ensure that people have accurate information about how and where to access services.
Is there a written plan that's being put together, or is there one? And if there is, can we get a copy of it at some point, or you can share it with the council? Because I think it's very important for us to know that too, because we can also help to be ambassadors for that.
Absolutely, yes. Council are critical ambassadors in that. We're working on that plan and the timeline now and are happy to follow up with council.
Okay, thank you. So DOH-MH's Center for Health Equality addresses health inequities and provides data on maternal mortality. The Race to Justice initiative is also particularly noteworthy as it is an internal reform effort committed to better addressing racial health gaps and improving health outcomes for all New Yorkers. Can you describe the education and training provided to staff and how this helps address health disparities?
Thank you again, Council Member, for this question, Chair, for this question. What I can say is that we are very proud of the work that our Center for Health Equity and Community Wellness has done. It was established in 2014 under former Commissioner Bassett and then was actually expanded in 2019. It is, in fact, the division that I lead. There are multiple areas of work within our division. And we do work that is focused on various areas. Some of our work is focused on place-based approaches through our action centers, which house community-based organizations, health department staff, and other team members to be able to really invest in the communities that we know have experienced disinvestment. We also have strategies around community health workers, as was already described, doulas, and we do lots of different trainings for health equity for both our staff internally as well as our community-based partners. So in summary, I would say that our work over the center has grown significantly since the center was established in 2015, and that includes the work of the Race to Justice team. And we would be happy to share more details with you about the center's work in follow-up to the hearing.
Okay, Race to Justice includes efforts to create a workforce that most closely reflects diversity in New York City. Can you explain what those efforts entail?
Thank you for that question, Chair. Yes, the Race to Justice initiatives that the Health Department leads are focused on multiple different areas to advance anti-racism and health equity. Some of those efforts do include specific work around increasing people of color in both health department and in healthcare delivery organizations and institutions. Some of those efforts are really focused on how we work with our human resources colleagues to recruit and to make sure that the recruitment materials we use are reaching communities that may not always be reached. And we also do multiple efforts, again, internally within the health department to make sure that there are teams across all of our divisions who are experts in both racial justice and health equity who can help make sure that there's not only one team centrally, but multiple teams across multiple divisions to be able to advance this work.
Thank you. I have to skip out for 1 second for something urgent. Chair Narcisse is going to take over the questioning for now. Thank you.
Thank you. One of the things that I have people, doulas complaining during the height of the pandemic, that it was a choice between them or the partner in the room. How could we put some policy or some enforcement toward that to make sure that doula can participate in the room when the maternal person needs them the most?
Thank you so much, Chair Narcisse, for that question. We are aligned with you 100% on wanting to make sure that doulas are welcomed in hospitals and healthcare settings, and that hospitals, health workers in hospitals, and others understand the role that doulas play, the critical role that doulas play in accompanying birthing people. So we're very aligned with you on that. In fact, during the COVID pandemic, we had not only relationships and partnerships with community-based organizations who were advocating to make sure that doulas could still be in the room to support birthing people, but we also worked actually with multiple other partners to ensure that hospitals understood how they could be respectful of doulas and make sure that doulas, again, were involved and included. The final thing that I'll mention is that we also had a perinatal task force during COVID, and that task force specifically focused on what you're describing, making recommendations and ensuring that doulas could be present for birthing people throughout the COVID pandemic.
Sorry that I had to mention that before I come back to where CM Schulman, who was chairperson, was in. Research suggests the solutions to addressing maternal mortality lies outside of hospital walls. Has the Center for Health Equity worked with outside agency on their internal reform efforts?
Thank you so much for that question. And yes, it's very, very important to mention that the large majority of maternal deaths do occur in the year following delivery, and that a smaller portion, about a quarter of them, occur in the hospital and during pregnancy. So we agree with you, Chair Narcisse, that this is incredibly important, that the whole entire life course is supported, and that work happen both within the hospitals and, very importantly, outside of hospitals as well, to ensure birth equity and to ensure that all women and pregnant people have access to the care they deserve. To your question about how the Center for Health Equity has worked with other agencies, it's a really important question. In fact, we have family wellness suites located in our action centers, and the work of those family wellness suites is in relationship and in partnership with many different other city agencies, including ACS and Health and Hospitals, amongst others. So we have developed those kinds of partnerships, and we do seek to continue to engage other agencies in our work. I should also mention that behavioral health, overdose, and suicide are unfortunately very, very common causes of death in the year following pregnancy, and we continue also to work with other partners in the behavioral health world to address that.
So, can the family can see the baby as well when they come in? Can they be in the room?
Chair Narcisse, I'm sorry, can you clarify?
I said, can they
the
be in the
question?
room to participate? I mean, when they come, can the family comes in the room as well?
Do you mean in the hospital?
In the hospital setting?
Okay. I think for that question, I'm going to pass to my colleague, Dr. Michelle Allen from Health and Hospitals.
So, first of all, I want to state that I really appreciate this hearing for bringing these issues to light. I also want to state that I'm very proud to be sitting next to Dr. Michelle Morse, whose reputation preceded her, who fought for diversity and equity and inclusion before there was a DEI, to the point that she was threatened in her previous employment based on her vociferous and passionate.
It's hard for me to hear because the mic is kind of far.
I'm saying thank you to the council.
Bring it down a little bit. Just bring the mic down. Just bring the head, yeah, a little closer, yeah.
Thank you for having this hearing. I've been an obstetrician for 40 years, and I appreciate the spotlight on maternal morbidity and mortality. And I also was saying what an honor it is to sit here, next to Dr. Michelle Morse, who was committed and passionate about diversity, equity, and inclusion before there was a DEI, to the point that she was actually threatened in her job and her life based on her commitment to these issues. To speak about visitation rights during the pandemic, H&H actually allowed the family, as well as a support person, to be with the patient throughout her labor and delivery. This was our commitment. It was the health department's commitment. And after the baby was born, as you know, in our hospitals, we have rooming in. So in the room, you have the mother and the baby, and one visitor was allowed.
Thank you. Most deaths occur within 1 year after giving birth. What can we do better to address the parent's health? For example, when babies go for their 6-month visit, can we do better to ensure the parent receive care too?
One of the things that we have done at Health and Hospitals is co-located the postpartum visit with the well baby visit. When you look at how we as moms comply with our own health care, we are much better in taking care of our children than ourselves. So you look at the postpartum no-show rates, they're high. Our compliance, our ability to make those visits for various reasons is difficult. But if you look at the compliance with the well baby visit, that 4 or 5 week visit after the baby is born, that's a 98% compliance. So we have started in Health and Hospitals to co-locate and coincide the postpartum visit with the well baby visit. So when the mom or the dad brings the baby, the mom will show up, blood pressure, if she had gestational diabetes, how's her diabetes doing. And the whole purpose of this is to get the woman back into primary care. I think for most of us in our reproductive years, our gynecologist is our primary care physician, which is fine, but we really need to detect those things that cause maternal morbidity before the woman becomes pregnant. So we've also implemented within Health and Hospitals in the primary care visit a pregnancy intention question. Are you planning on becoming pregnant? And if you are, then the referral is made to the GYN clinic so you can have prenatal conceptual counseling. If you're not planning on becoming pregnant, then we will refer you to GYN for the appropriate effective contraception of your choice. The whole point of that, if the woman is in prenatal care, if she's in primary care and she has diabetes, hypertension, if we can get that in control before she conceives, I think it would make a big dent in how we do during the pregnancy and the pregnancy outcome.
I'm in total agreement with that one, because one of the things that we have, especially in the Black and brown community, is diabetes, hypertension, the underlying that never been addressed. And that's by the time the person getting to give birth, preeclampsia and all. That's great. Thank you for that. I have some other question. Just bear with me 1 second. So what is the population? Now, before I get to the other question, what's the population, like we say, what's the percentage of your population of mothers that end up with, I know last time we said the numbers cannot be told. I want to know for each hospital, for example, how many of mortality that you have. Is that possible that you have that on the record, especially when it comes to H&H? I would like to know.
Thank you, Chairperson, for that question. One of the many programs that we run at the New York City Health Department is the Maternity Hospital Quality Improvement Network. And that network was launched in 2018. And one of the things that that network does is it really works with hospitals around their data on severe maternal morbidity and mortality. We also do publish every year a report that describes maternal mortality, and it describes that information by borough and by race and ethnicity. And that is another source of really important data to make sure that we're able to follow the trends over time across hospitals across the city.
So what's the number specifically?
Which,
for the H&H, that for mortality that you have?
For health
maternal mortality?
For Health and Hospitals, I'll pass to Dr. Allen.
I don't have those numbers with me today, but I'd be happy to share them with you after the committee hearing.
Thank you. Black women and birthing people are 8 times, we mentioned that, 8 times to 12 times more likely to die from pregnancy-related death than white women in birthing people in New York City. Additionally, according to DOHMH, data for severe maternal morbidity rate among Black non-Latina women was 3 times that of white non-Latina women. Research has shown that regardless of education and other factors, Black people are more likely to die or nearly die from giving childbirth, right? Can you discuss why we see these disparities?
Thank you again, Chair Narcisse, for this question. This is very fundamental to the work that the Health Department is doing, is really understanding, to your point, the upstream causes, as well as making sure that we're working hand in hand with hospitals and healthcare delivery institutions as public health. And in fact, my job as Chief Medical Officer, in large part, is related to making sure those partnerships work so that we can do more prevention work. Your point about the fact that these racial inequities in birth outcomes are huge and persistent and unjust is critically important. In fact, the Board of Health for the New York City Health Department declared racism a public health crisis in October of 2021. And that resolution that was passed by the Board of Health was a landmark resolution that not only described many of the drivers of those racial inequities in birth outcomes, but it also requires the Health Department to report twice per year to the Board of Health and to explain the progress that we're making in addressing those root causes. There are a series of 9 actions that the Board of Health resolution has required that the Health Department take, and much of the work and programs that I presented in my testimony today are in line with the resolution and the accountability that we have to addressing racism as a public health crisis.
Thank you. I'll pass it on to. Oh, Nasia Shulman. Okay. The severe maternal morbidity rate was also notable high among women who were Puerto Rican and of other Latina origin. Can you speak to the disparities as well?
Yes, thank you so much for that question. And one of the things I want to pass to my colleague, Dr. Tara Stein, to talk a little bit more about that question specifically, but I do want to start by saying that one of our key priorities in terms of ensuring access to healthcare is also ensuring that that access to that healthcare is in the language that's preferred by the person who's seeking the care. And we do know that lack of access to language services is a driver of health outcomes, and it's something that we prioritize very much in our work at the Health Department. I'm going to pass to my colleague, Dr. Stein, to share some more.
But before that, I have this number here, the data. So 272 per 10,000 deliveries when we're talking about the Latina origin. That's a lot. And 248.5 per 10,000 deliveries.
Yes, Chair Narcisse, we are aligned with you in that we think that the rates of inequities are too high and that the racial inequities have to be reduced. I do want to ask my colleague, Dr. Stein, to speak a little more specifically to the numbers you just mentioned.
Yeah, but I don't want to confuse you. The one, the 272 was from Puerto Rican descent specifically, and the others is from 248.5 is just Latina origin. Go ahead, thank you.
Thank you so much, Dr. Morse, and thank you, council members and Chairperson Narcisse, for this important question and calling our attention to these issues that face the birthing and parenting people of New York City. We at the Department of Health are aligned with you and your passion and commitment to making sure every New Yorker has the ability to become pregnant and parent those children when they want them. As a family physician myself, I am firmly committed to ensuring all people have access to this care and healthy deliveries. We do rigorous review of all maternal death events in the city, and we are committed to identifying the root causes, and oftentimes we do find there are systemic causes. As Dr. Moore said, racism is a public health crisis, and we need to continue to identify and work with those root causes when every tragic death occurs, so that we can recommit our programs and our priorities to identifying and improving the outcomes in the populations that need it most intensely, and to focus our programmatic work to align itself with the data as we identify it. So these numbers are critical, they're devastating. We recognize the impact that this has on specific communities, and we're always looking to partner with community-based organizations in specific groups to make sure that those who need the care can get it. Thank you.
Thank you. In addition to discrimination in hospital settings and care, what other factors contribute to racial disparities in maternal health? And what are DOH, MH, and HNH doing to address them? How does implicit bias come into play in the hospital setting?
Thank you for that question, and we do appreciate you getting at the upstream causes. And as Dr. Stein mentioned, I think specifically we also know that inequities in housing, for example, we know that there is a history of redlining, which is a policy of our federal government that led to really different housing access and housing conditions across our entire nation. Housing is a social determinant of health, and it's a determinant that impacts health outcomes and birthing outcomes for pregnant people across the city. And it is racialized. It is driven in many ways in terms of access to stable housing by systems and policies that unfortunately are rooted in racism. So we know that housing, education, transportation, stable work, and economic stability, these are all different determinants that really influence the success of our programs, and also, of course, the ability of a pregnant person to have a healthy pregnancy. In terms of implicit bias, it's a phenomenal question. In fact, a lot of the research out there shows that more trainings on implicit bias can impact the perceptions of clinicians around their own understanding of how racism operates and how other systems of bias operate. One of the pieces of the Maternal Health Quality Improvement Network program that I mentioned is implicit bias training. In fact, we can report, and we're happy to report, that over 1,000 health providers have been trained in health equity, anti-racism, and implicit bias as a part of the MHQIN, sorry, it's very long, Maternity Hospital Quality Improvement Network. When the cohort was launched in 2018 and just finished the first cohort in December of 2021. So over that time period, 1,000 providers were trained in that area.
I'm happy to take that.
And I'd like to pass to Dr. Allen to add some more comments.
So there's a lot of research, not a lot of research, but we're starting to look at the role of stress, intergenerational stress, and its impact on the pregnancy. So research, we do have some research in the behavioral health field looking at survivors of the Holocaust and how that stress of the Holocaust has been passed down through generations from the survivors of the Holocaust. And we're beginning to look at that, as well as the impact of slavery and the 400 years of oppression in this country and what impact, long-term impact. And as you know, if you correct for education, for social class, for economic class, both maternal mortality and infant mortality still has a disparity between races, white and black races. That having been said, I would like to share with you some of the work that's being done at health and hospitals to address diversity, implicit bias training, and training about bias as well. Many of you may be familiar with our simulation program, where we simulate the complications, the rare but devastating complications that occur in pregnancy: shoulder dystocia, postpartum hemorrhage, cardiac arrest. We've also started a simulation training for bias. How do we train our providers to ask questions and provide care and become aware of their own internal unconscious biases? So we've just developed a curriculum and we've just started to roll it out. In addition to that, in our Human Resources Department, we have an Office of Diversity, Inclusion, and Equity. We have e-learning modules. We have an Introduction to Unconscious Bias. We have a business imperative of diversity of inclusion. Over 20,000 employees have completed these trainings since January 2000. We also have an employee voices sessions, anonymous conversations with employees on the topic of implicit bias and racism. They're designed to give the employees a safe place to share while learning concrete action steps to mitigate the bias. We've held 6 of these sessions in the last quarter. We also host a variety of virtual workplace inclusion workshops year-round that include the following topics: diversity and inclusion in the healthcare setting, interreligious awareness for patient-centered care, having essential conversations. This gives tools and techniques for having essential conversations on the topic of racial equity, how to be an inclusive colleague, how to be an upstander. Those are just a sample of some of the trainings that we have for our staff throughout H&H. In terms of diversifying the workforce, because the data is actually very clear that patients do better if they have a provider that looks like them or shares the same culture. We're developing a pipeline and pathway with medical schools so that we can identify young students of color who are interested in science, technology, math. And we've just started a Mosaic program with Morehouse, the University of Puerto Rico, and we're working very closely with CUNY so that our workforce in health and hospitals can look like our patient population and hopefully make a difference in the outcomes across the board, not just in obstetrics and gynecology, but internal medicine, surgery, et cetera, just to share how we're thinking and what we're doing to make a difference.
Thank you. What do you think of doula program, doctor?
So I have a 2.5-year-old granddaughter who's the apple of my eye, whose mom, my daughter, had a doula whom she identified during her pregnancy, who, thank God, was with her during the labor and delivery and visited her at home postpartum. So I'm an advocate, a personal advocate and proponent of the support that doulas provide.
Yes, I heard you, Doc. Social determinants are crucial. Can you please elaborate on how the Mayor's Doula program provides support to people in need of assistance with housing, food, domestic violence, and other social needs?
Thank you for that question, Chair Narcisse. We are, again, just very, very honored that we have the support from this administration to expand our doula programs. Initially, they were only in Brooklyn, and now with the citywide doula initiative, we have been able to expand doula support services to all 5 boroughs across the city, which is a very exciting expansion. We also are very happy to report that already, since this initiative has been launched, we have been able to actually train over 200 doulas. We're having a Mike Pence moment. We have over 200 doulas that have been trained already in health equity, birth equity, and several other topics, including mental health, addressing mental health as a part of the citywide doula initiative. One of the key parts of this program is, as you described, how to screen and refer patients who might have food insecurity or other social determinants of health concerns as a part of the program. And I just want to say that that has been a part of our doula work since the health department launched it in 2010, actually. And a part of the work that our action centers do in Brooklyn, in Upper Manhattan, and in the Bronx is actually to help to refer community members to the social services that they need based on what they come to us asking for. So the piece around connecting community members, including pregnant people, to health and social services is very central to our approach at the health department, and I'm so thankful that you're raising awareness about it, because we see that as one of the ways that we get to birth equity. And Dr. Allen, please do add.
I just want to share with you that we've actually have started a pilot program at a couple of our facilities where we're actively referring the pregnant people who are interested to the doula services in their community. We actively refer to ancient song, By My Side, and we've been doing this actually through a number of facilities, but this is a more rigorous pilot. We're actually tracking the outcomes, how the women do.
Thank you. Do you think that maternal health is a public health issue that we have on our hands?
Thank you so much, Chair Narcisse. We see this as both a public health and a health care issue for sure. And again, in my role as Chief Medical Officer, a big part of what I hope to do and what I am being held accountable to do is help to make sure that there's a seamless connection and partnership between our healthcare delivery institutions like health and hospitals and us at the Public Health Department. So we do see this as a public health issue, and we are thankful that this council is also seeing it in that way.
Thank you. So why does the U.S. not treating maternal health as a public health catastrophe that it is? What do you think? But rather to make it, you know, it's nothing and just not developing anything to change it. What do you think? Especially in our communities, Black and brown communities.
Chair Narcisse, I think it's a very, very good question. In my role at the New York City Health Department, I would probably not comment so much on the national concerns, but I will say
But national concern, we need to have it, especially after Roe versus Wade. Come on.
Yes, I agree with you.
You have to pay attention to national.
We certainly do pay attention to the national trends. I just can't speak to the federal level about what they are specifically focusing on. But I will say that the CDC also declared racism a public health crisis. And so I do hope to see more work from the CDC. In fact, they have launched a few years ago an ongoing campaign called Hear Her. And that campaign is specifically about making sure that providers and other community members also have the information they need to make sure that people who are pregnant know their rights and get the care that they deserve and are listened to and heard whenever they may be raising a health concern or another issue, and that providers are, aware that one of the drivers of birth inequities is not listening to patients when they bring a health concern. So the CDC's Hear Her campaign is perhaps one example to share. I just shouldn't really comment on the federal policy at this time.
I understand, but you almost bring me back to the emotion that I started when you're talking about the lead paint in the housing, the inequities in the housing. So I'm looking forward and listen to see what you offer to that, because we know the problem I have during the height of the pandemic, we all knew about all the inequities we're talking about, but no one addressing them. I don't want these inequities that we're talking about pre-pandemic to continue. So please continue focusing on maternal health. It's very important. Thank you.
So,
I will pass it on to Chair.
thank you. Obviously, this is a big topic. We have a lot of questions. I'm going to go out of turn and ask Majority Whip Sylvina Brooks Powers to ask a few questions and then come back to me. She has a hearing that she has to attend. So, Council Member?
Bear with me. Thank you so much, Chair Shulman and Chair Narcisse, for convening today's critically important hearing. Black maternal health care is an issue near and dear to me as a Black mother, especially to my young daughter, and representing a community that's predominantly Black as well. This issue is of utmost importance. When we hear of these statistics that quote-unquote Black women experience maternal mortality 2 or 3 times higher than that of white women, it is estimated that the Black maternal mortality rate is every 43rd out of 100,000 live births that end up in death, and that's alarming and clear that it's a national emergency. Repeatedly, we hear of horror stories of Black women not being treated with the same respect and not being heard. In April 2022, the CDC released a report working to reduce Black maternal mortality, highlighting the underlying racial disparities, implicit bias, lack of access to quality health care, and socio-environmental issues that attribute to these heartbreaking numbers. Legislation like Introduction 472 to establish a pilot program in the Department of Health and Mental Hygiene to train doulas and provide doula services to residents in all 5 boroughs, provide life-saving resources and information for expectant mothers of color. They also help with early detection of potential issues. Proaction is always better than reaction, and that is the same with Black reproductive care. Intro 478, that would require DOH-MH to report on polycystic ovary syndrome and endometriosis, can help Black mothers plan appropriate steps to combat potential health care issues and can offer a pathway to motherhood. I just want to underscore that as someone who has endured procedures as a result of cysts on my ovaries and fertility issues. I know this firsthand in terms of how we as women of color are impacted, how it impacts our pursuit of being able to expand our family. And so we need to make sure that we're investing resources so that our race, our socioeconomic status does not preclude us from expanding our families. And so just going into, I only have about 3 questions. So regarding Intro 472, how does DOH-MH evaluate the feasibility of a doula pilot program, including staff and funding, and how would the agency identify neighborhoods and areas across the city to introduce this program and ensure it's reaching New Yorkers equitably?
Thank you so much, Councilmember, for that question. We are very aligned with you in wanting to address the upstream social determinants of health, and we do, to your point, see doulas as one of the ways to do that. Not just for the accompaniment they provide, but also as described, the connections to resources that they can offer. One of the ways that we assess feasibility is, we're very honored to have been doing doula both services as well as training since 2010. Before it was as widely recognized as it is now as an intervention that advances birth equity. And so that experience over the past 12 years has been very helpful for our teams in trying to figure out, again, how we continue to expand doula services to all 5 boroughs. And then for the second part of your question about how do we figure out where to prioritize those resources, what geographic communities, and what is our place-based approach to really ensure that the families and pregnant people that need it the most really have access to doula services in a way that cost is not a barrier. The way that we have done that so far in the citywide doula initiative, which was just launched this March, is to focus on the TREE neighborhoods. So that's the Task Force on Racial Inclusion and Equity. These are 33 priority neighborhoods that we know experience high social vulnerability and economic stress. And unfortunately, many of those neighborhoods also had a disproportionate impact from COVID.
And then how has DOH-MH engaged with community-based organizations to explore how doula services can be expanded and supported?
Yes, thank you for that follow-up question. And I'm honored to be able to say that a big part of the work we do in the Center for Health Equity and Community Wellness is working with community-based organizations. We have several community-based organizations that are co-located in our action centers, and we partner very, very closely with them. Specifically when it comes to doulas, you are correct, that has been our strategy. In fact, the Citywide Doula Initiative, a part of the way that we expanded that program from Brooklyn to all 5 boroughs was to do a request for proposals, an RFP, for community-based organizations that employ doulas, and many of them are led by doulas, to respond to the RFP and be funded to be the I guess you could call it the implementation arm, the organizations that are actually working with us to expand access to doula services. And so there are 7 community-based organizations that were funded through the Citywide Doula Initiative to be able to expand doula services across all 5 boroughs.
Thank you so much for that response. I just asked offline if you can share the list of those organizations with my office. I would love to know which ones they are. And please use my office also as a resource, because I do represent a hard-to-reach community when you think about us being geographically isolated. And it's something that is, again, a very critical issue for the community I represent. And I want to thank the chairs for the opportunity to ask my questions. Thank you.
Okay, thank you, Councilmember. I'm going to ask a few questions. There's a lot more that we have, but I want to, 2 things. I want to let my colleagues answer. We have some panels who want to talk. We have to be out of this room at 1 o'clock, so, because there's another hearing. But I want to, okay. So I want to focus on the bill that I introduced, Introduction 509. Do you agree with the notion that pregnant people in New York City would benefit from a campaign about the risks of C-sections? That's intro.
Thank you, Chairperson, for that question. We are very much in agreement that there needs to be awareness-raising campaigns, and we also agree with you that it's very, very important for patients to have all the information they need to know the risks and benefits of any procedure. However, we know that sometimes C-sections are necessary, and our concern would be that we don't want to stigmatize cesarean sections because some patients do need cesarean sections. But what we agree with you for sure about is that we think it's very important to decrease the rate of unnecessary cesarean sections. And many of the hospitals we work with are very much aligned with that. I do also want to underline again that doulas, as well as midwives, have been shown to decrease the rates of cesarean sections. And so the work that this council is already doing to support doulas and midwives is very, very important.
Oh, I appreciate that. So I'm going to ask some questions about fertility. What is the current amount that the city spends towards fertility services like IVF for city employees?
I'd like to pass that one to my colleagues
Yeah,
at OLR.
I'm looking right at it.
Thank you for the question, Chair Schulman. The city currently spends over $100 million on fertility benefits for city employees.
Okay, if non-heterosexual couples were included in IVF coverage, how much would that amount increase?
So non-heterosexual couples are included in the city's infertility benefits. What is not included is surrogacy. So surrogates or IVF involving surrogates is not currently covered. We don't have precise figures on the cost of adding surrogacy benefits, but we do know that surrogacy costs are very expensive.
Okay, so you don't have any estimate or anything like that?
Not at this time.
Okay. Does the city do outreach and education to city employees so that they're aware of their coverage options?
Our fertility benefits are set forth in the city's summary plan description, which is available to all city employees on OLR's website, and lists out the benefits, all the health benefits under our health plans.
Does the city provide any reimbursement toward out-of-pocket expenses relating to fertility services?
So it depends on the service. If you're talking about an out-of-network provider, if someone was going to an out-of-network provider for covered infertility services, there could be reimbursement through the primary health plan. In addition, some welfare funds run by unions may provide some degree of reimbursement for out-of-pocket costs. For example, the Management Benefits Fund, which is available to non-represented employees, has a superimposed major medical plan, which would provide some additional reimbursement for out-of-pocket costs.
If the city's insurance also covered fertility preservation like sperm or egg freezing, which is generally less expensive than IVF, Wouldn't that help same-sex couples and uncoupled individuals conceive?
I apologize, I'm just considering the answer. So, I think there are a number of services we don't cover, obviously, and, I think the question of what would assist some of our employees in conceiving when they may not be ready to conceive now, that's certainly something that would help them, and it's something that, is worth exploring. I don't know the extent to which what numbers of the employees out there desire to use those benefits, but I'm sure they are out there.
Well, so my next question is, why isn't fertility preservation like egg and sperm freezing included within the 3 rounds of IVF that are covered?
So it is included where, egg freezing is included where someone's undergoing a procedure that could impact the viability of the eggs. So, kind of the premise of our benefits, which is based on, the state mandated benefits, is when someone is not able to conceive the traditional way. So those services are covered where someone has, been diagnosed with infertility or because they're unable to conceive despite earlier attempts to do so.
Understood, but the implication of and then why we did the legislation is because that actually discriminates against LGBTQIA couples, those who are uncoupled and asexual. So I know there's some disagreement around that, but I just want to point that out. I mean, I'm not going to debate it here. But.
I appreciate that, Chair Schulman.
So thank you on that. And I just wanted to ask on, excuse me 1 second. So implicit bias training, let's go back to that for 1 minute. Since 2018, bias training has occurred within relevant private and public healthcare facilities across the city. Can you provide an update on these? You did that? I'm sorry. So let me ask this question. When you do the training, does that also cover the affiliation agreements for the doctors that are affiliated with other hospitals that work at H&H?
I think for the H&H specific question, I'll pass to Dr. Allen.
Dr. Allen.
Yeah. So thank you for that question. We have done system-wide anti-bias training, bias awareness training. We actually started with the board of directors and our senior leadership.
Okay.
And we, in conjunction with DOH-MH, involved our frontline staff at each of our facilities as well. And we're doing through human resources additional anti-bias training, diversity training, so it's a full court press. I had gone through this earlier. If I put my glasses back on, I can tell you exactly what we've done. If you could just give me a minute. Just to go through some of the stuff that's offered through Human Resources. We have an introduction, we have e-learning modules. Introduction to unconscious bias, diversity inclusion, a business imperative. We've trained over 20,000 employees since January of 2020. Okay. The modules on this topic are also integrated into our new employee orientation and annual in-service. We also have employee voices sessions. These are anonymous conversations with the employees on the topic of implicit bias and racism. They are designed to give the employees a safe place to share while learning concrete action steps to mitigate bias. We've had 6 of these sessions within the last 3 months. We also host a variety of virtual workplace inclusion workshops year-round that include the following topics: diversity and inclusion in the healthcare setting, interreligious awareness for patient-centered care. It gives the employees skills to meet patients' religious and spiritual needs and to respectively interact with colleagues from different faith backgrounds. Having essential conversations, which provides tools and techniques for having essential conversations on the topic of racial equity. How to be an inclusive colleague, which helps participants gain the essentials of inclusive behaviors to support a welcoming workplace environment. How to be an upstander, which guides participants through proven techniques to actively address and mitigate instances of biased encounters. Over 1,100 employees have participated in the above virtual sessions since July 2020. And in our simulation lab, where we learn how to react to rare but serious instances like postpartum hemorrhage, shoulder dystocia, we've actually just developed a curriculum for recognizing bias and dealing with patients. So we're taking our, and when you go through the simulation lab, you don't go as an individual, you go as part of a team. So you have your nurses, your doctors, your residents, as well as your administrator participating as a group. So we've just started that curriculum on anti-bias. It's particularly important to us because in recognizing the substance use disorder and impact on the pregnant woman and her family, her fetus, the siblings of the newborn child, the father, the family, we recognize in assessing and doing substance abuse screenings, personal biases actually come in. So if you look a certain way, our response might not be the same as if you looked a different way, including the color of your skin, the texture of your hair, the clothes you're wearing. So as we're developing this substance use disorder identification and intervention, and from a preventive perspective, it's very important to us that our providers are sensitive to their own biases as we begin these screenings and identifications.
And just, I want to ask, are these trainings mandatory?
So I can't answer from the human resources. Well, it's part of the new employee orientation, so I don't think you can opt out.
Okay. All right, thank you very much. What I'm going to do, in the interest of time, is go to my colleagues, and then we can, if we have a chance, we'll circle back. I'm going to ask Councilmember Gutierrez to ask you questions. Thank you.
Thank you, Chair. I have a lot, but I will not ask all of them and to make sure that we're all getting our questions in. My first question is, how many hospitals have midwives on staff, and how many midwives does DOHMH employ?
Thank you for that question, Councilmember. We are aligned with you in really prioritizing midwifery for the reasons already mentioned, that it's shown that both doulas and midwives decrease cesarean section rates and really, again, are critical health workers to advancing birth equity. I don't believe we have that information for you about specifically how many midwives there are per hospital across the whole city, but I will pass to Dr. Tara Stein to share more about our midwifery initiative in the health department.
Okay.
Thank you, Dr. Morse, and thank you, Councilmember, for the question. We are extremely excited at the Department of Health about our new midwifery initiative. And we are in the process right now of hiring a senior advisor on midwifery initiatives who will be the first midwife to be hired at the agency. We have long known the importance of midwives and the role that they play in improving health outcomes for parenting, pregnant and parenting people. So we are really looking forward to this new position. And much of the role of the midwifery initiative and this new hire will be to assess the status of midwifery care and to help describe some of those things that you're asking about.
Thank you. I would love to follow up. My understanding, oftentimes with midwives, if they're not full-time on staff, I know that they will freelance, or maybe it's the doulas that I'm confusing it with, so I think it would be really helpful to have that data. My next question is, you mentioned, in hospital level data kept and analyzed regarding rates of maternal mortality and morbidity is information about maternal mortality and morbidity, do you all have it by demographic populations?
Thanks again for that question. And it's very much in line with what we're required to do by the Board of Health resolution declaring racism a public health crisis. But in fact, even before the resolution was passed last October, the Health Department did collect that information about race and ethnicity and maternal mortality by race ethnicity. It is a part of the annual report that we publish online, and it's freely available for researchers, for others to look at that data and to use it to continue to develop programs that might reduce racial inequities in maternal mortality.
Fantastic. Can I ask you, you had talked earlier about the suicide being really high for new moms, new parents in the first year. Can you talk a little bit about how the Midwife Initiative will be able to aid these moms in these instances, and what are some of the action plans that are in place now to really prevent this from happening, and really talking through new-time parents when we're talking about suicide prevention?
Yes, thank you again for that. I think for us who've been doing this work for some time, it's not surprising to see how much behavioral health is central to health outcomes for everyone that we take care of. So thank you for raising more awareness again around behavioral health and suicide, and overdose as well is a significant driver of deaths in the year following delivery. I would actually like to pass to my colleague Laura Lewison to speak a little bit more about the New Family Home Visit Initiative and how it might help to address what you're describing.
Thank you, Dr. Morrison. Thank you so much for this question. I'm a clinical social worker by training, and so maternal mental health is a priority, a personal priority for me, but it's also a priority for our work. And as you're pointing out, Councilmember, suicide does not happen in the hospital context. It happens postpartum, when many of the maternal deaths we know occur. We are really excited about our New Family Home Visiting Initiative and the expansion that was announced in the past year, because that initiative will really allow us to support families during that incredibly vulnerable period when you bring home a new baby from the hospital. So if you've done that, you know it can be a really hard time, particularly if you're already struggling with other concerns or other mental health concerns in your life. Our New Family Home Visiting Initiative expands a wide range of evidence-based home visiting programs, as Dr. Morse mentioned earlier, including Nurse-Family Partnership and Newborn Home Visiting, and the citywide doula initiative. A critical component of this expansion will be enhanced support for mental health. That was a recommendation from our Maternal Mortality Review Committee, that all pregnant and postpartum people should be assessed for mental health conditions, substance use, interpersonal violence, and that those who screen positive, those who indicate a concern, should be referred to supportive services. And so our New Family Home Visiting Initiative is currently working on a strategy to support mental health for those new families.
Thank you. I know my time ended. Can I just make one more comment and then, can I just make one more comment before? So I've talked about this publicly many times about my experience at Woodhull. I was really, really lucky to have a midwife and a doula there present for me. I just want to shout out all the trailblazers coming out of all of our public hospitals, but specifically Woodhull. I also just want to emphasize that when we're talking about our public hospitals, wherever they are, I think it's really important that we're talking about how these midwifery programs are being mitigated and that they're equitable across the board. What I don't want to see is that we're seeing some thriving programs in Coney Island, but we're not seeing the same at Woodhull or Lincoln, for example. And so I know that we have a mayor and an administration and certainly a council that wants to prioritize all the things that we're talking about today, because I think we all know how important it is. But how can we ensure that when we're talking about this initiative, that when we're talking about career pathways, that when we're talking about the opportunities that every New Yorker has access to, that we're doing it as equitably as possible, that we're not letting programs, hospitals, midwifery programs fall through the cracks. Because I really think, although this is a really important thing to celebrate today, what we're doing, I don't think it would be in earnest if we're not doing it equitably. And what I don't want to see is that we're not getting the same level of support in Coney Island or Elmhurst that we're not getting somewhere else. So what can you all tell me about how you are ensuring that this is done equitably every single time at every single public hospital to begin with?
Thank you, Councilmember. We're aligned with your intent 1,000% around equity and how we operationalize it. I'm going to pass to Dr. Allen for the health and hospital specific question.
So health and hospitals is a system, and what we implement system-wide. So I'm not sure if you're referring to suicide prevention or anything specific, but let me share with you that when we look at mental health services for our women, every single woman, no matter what hospital she presents to in labor, and actually no matter what hospital or facility she presents to for her prenatal care, she gets screened for depression, the PHQ-2 and the PHQ-9.
I was screened every single visit, and so that's really meaningful.
Okay. So we do it during the pregnancy, and we also do it postpartum. There's actually a specialty called reproductive psychiatry, and we work very closely with a couple of reproductive psychiatrists who are supporting us in our prenatal care as well, and we're building that. But I can only say that we are a system. When we're talking about midwives, we are implementing that. I actually want to spend a little bit more time talking about our midwifery services. So currently, we have midwives in 8 of our 11 facilities, but we are expanding that. We actually have funding from the New York Community Trust to do a thorough evaluation of a midwifery care throughout the system. We're actively hiring more midwives. We've hired an additional 20 in the past year. We have a council of all of the midwifery chiefs throughout all of our systems. Once the evaluation and analysis is complete, the midwives themselves will have control over what's the best model of care to deliver midwifery services in health and hospitals. We have a very close collaboration with our midwives. We're committed to building the service and strengthening the service throughout all our facilities.
Okay, I'm going to ask the council members, since we have a time constraint, to please keep to their allotted time. I'm going to ask Councilmember Joseph to ask questions.
Thank you, Chairs Shulman and Narcisse, for this very important conversation. My questions are a lot, but I'll keep it short. Thank you for touching upon curriculum. As the chair of education, that was very important to me in terms of implicit bias. I don't think it should start in the hospitals. I think it should start at the nursing schools, at the medical schools. It shouldn't wait till we get inside the walls of the hospital to practice bias implicit training. It should start there. But the fact that you're doing it in the hospitals is very important. A few questions on language access for our mom-to-bees. Is that being implemented? Do they understand midwife, doulas in their native language and also in culturally relevant settings? Is home visit provided after care, which I think should be very important to check up on the moms, especially the ones that don't have any support. So I would like to know where H&H is on that. Either one could answer. We know that dismantling this racism, this racist health care initiative should not only start behind the walls of the hospital, but I believe that it should also start within the community and working in partnership with CBOs. Let me know how that work look like. Explain to me what your partnerships are on the grounds and how are you supporting these things. Thank you.
So I think the answer will be longer than the question. Language, we have many different languages that are represented in our facilities, from Queens. Can you hear me? Better? So we do have, and we appreciate the difference between someone whom has learned Spanish or another language in school versus a native speaker. All the difference in the world. And it actually was very evident to me when we do the PHQ 2 and 9 screening for depression. If you're talking to someone who's not a native speaker, the idiomatic nuance of the language really makes a big difference. So we have access to what we call a language line where we can call for an interpreter to help us with our conversations. In terms of, we have a program called the Maternal Home Program, which is in all of our facilities. And even though we thought we would meet the needs of 2,000 patients over 5 years, within the first 2 years, we touched on 3,000 patients. In the year of 2021, we saw 2,100 patients, which represented 16 births, 16% of the births in H&H, and the majority of these were in Brooklyn, where 25% of the pregnant women were actually enrolled in the maternal home. 75% of these patients were either Black or Hispanic, and 25% were referred to community-based organizations. And the support we got from the community-based organizations, from the medical side, 59% received dental services. For pregnancy and parenting, 32% received lactation support, 22% received doulas, 13% were referred to the DOH-MH Nurse Family Partnership. So our involvement with the community-based organizations is very strong. We depend upon them. 14% were referred for community care, 20% collaborative care, 18% for nutrition, 35% were referred to WIC, 15% were referred to food pantries, 12% to SNAP, 8% for legal services, 5% for financial counseling, 11% for mental health services. So the community support's very important to us. We couldn't do our work without the community-based organizations. So we provide language access. I can't tell you the number of, and I'm happy to give you the number of languages that we have access to. I think on any given day we have over 20 or 30 different languages in our facilities. Any other questions that I didn't answer, Councilwoman Joseph?
No, it was about the home visit. You touched on that. And breastfeeding. I know that's not promoted among women of color and Latino women. I would like to see, is there a campaign in place? Is there something?
So we're all baby-friendly. All of our sites are baby-friendly sites, which is a designation by the World Health Organization. And I just wanted to say, in terms of community-based organization support, 32% of our patients were referred for lactation support. So that is encouraged. To have the WHO baby-friendly designation is, I think, a very good one, and it allows for our patients, so we're aware of the deficit that we've had with formula in this country. So we don't really depend on formula within our H&H facilities because we are such a strong proponent of lactation and breastfeeding.
Okay, thank you very much. I'd like to, before I go to the next council member, I want to acknowledge that we've been joined by Council Member Yeager. So the next person up is Council Member Julie Menon.
Thank you so much, Chair. First of all, I was pleased to hear in the testimony that you believe that my Bill 490 would codify the Bureau of Maternal, Infant, and Reproductive Health. So I have a number of questions on that. First of all, how many referrals is that Bureau currently making to women in terms of providing safe and affordable abortion services?
Thank you so much, Council Member, for the question and for your support around sexual and reproductive health. We do have a Bureau of Maternal, Infant, and Reproductive Health that handles this work, so I'm going to pass to Assistant Commissioner Lewison to share more.
Thank you, Dr. Morse, and thank you for the opportunity, Councilperson, to talk about our part of the Health Department. So our office, the Bureau of Maternal, Infant, and Reproductive Health, handles this work for the department. We work closely with our colleagues from the Bureau of Hepatitis, HIV, and Sexually Transmitted Infections, as well as the sexual health clinics, to ensure that we are providing services to New Yorkers really through what I would describe as a sexual and reproductive justice lens, so that all New Yorkers have the ability to make decisions about how, when, and if they choose to parent, and are supported with the appropriate resources, whether those are resources for, I think you mentioned testing or contraception. Within our sexual and reproductive health unit that exists within our bureau, we have some amazing work happening. I want to highlight the work of our program, the New York City Teens Connection, which is a program that is currently expanding across all 5 boroughs to support adolescents in linking them directly to services through clinics that are teen-friendly and providing them education and resources in the spaces where they are in schools and other youth-serving organizations. We are actively working, as I mentioned earlier, in close collaboration with our national and local partners to respond to the recent overturn of Roe versus Wade, and will begin to be developing implementation strategies for providing even more information about abortion access. I don't have numbers for you currently about how many folks we're referring to abortion services, but I'm happy to follow up with you on that specifically after
That
the
would be
hearing.
very helpful. And then as a corollary to that, how many staff are in that bureau, and what are the bureau's plans to ramp up in terms of the expected influx of women who are going to come to New York to seek safe and affordable abortions?
Thank you for your question. Our bureau has, I believe, over 200 people in it, and that includes a really wide range of professionals. In addition to the sexual and reproductive health unit, our bureau is also responsible for a significant portion of home visiting services within the city, including Nurse-Family Partnership and the newborn home visiting program that were mentioned earlier. And so our plan is to work closely with our colleagues to determine what are our needs for staffing, for infrastructure, in order to be able to really meet the increased demand that we anticipate.
Okay, and then my last question is, what are the Bureau's plans in terms of the fact that some states have threatened to restrict travel to women? What are the Bureau's plans to address that and to help relieve some of these burdens?
Absolutely, and I will say that we share your concern that we are seeing throughout the country efforts to really prevent people from accessing care by limiting their ability to travel or seek appropriate medical services that they choose. We are in close contact and really close collaboration with our colleagues to better understand what opportunities exist to support those folks who may be prevented from travel or for whom seeking abortion is a criminalized act. And we are working with our colleagues at the New York State Department of Health as well on this.
Okay, great. Thank you very much.
Thank you, Council Member. Now I'm going to ask Council Member Velasquez to ask her questions.
Okay, so I have a series of questions. I'll read them out. So because I know we're short on time. First of all, thank you. Thank you for coming. Today is very important to me. As I am currently doing IVF, I have several questions for you because it wasn't easy. It hasn't been easy. The communication, the way that the accessibility that we have wasn't there. So I advise you to go back into the program. Please let the providers know that. Additionally, there is a lot of out-of-network that is involved, and I know that the Win Fertility has been mentioned. However, when we were researching, me and my husband, it wasn't available to us. We did not know about Win Fertility, and it wasn't communicated effectively to us.
Thank you, Council Member, for those comments and thoughts. We will certainly go back and take a look at those issues. Win Fertility, my colleague Claire Levitt can speak more when it was established, so I'm not sure if your experience was prior to that, but we will certainly go back and try to ensure that the benefits that we provide are communicated effectively to our employees, and that employees going through this, what I know can be a difficult process, have aid, have access, have assistance, and can be directed on where to go and have somewhere to turn when they have questions.
We're certainly very concerned to hear that you had difficulties. Is there, if there's something that we can do to help assist you through the process right now, we certainly want to do that, and I can be in touch with you to make sure that we can make the proper connections for you.
As you know, so me and my husband have, full-time jobs, keeping me, up to date and making sure that we have accessibility, right? And if this is something I'm personally going through, what about the other city employees that are also affected by this? That's my problem with it, right? We have an opportunity here to say, you know what, let's reconfigure this so it can be accessible, right? Because accessibility is part of the ability to manage this situation and this health care procedure, right? It's a choice, right? What we're talking about today, it's like a choice. And we're not really providing our members with real accurate information, on-time information, and the outreach has been poor. We had to literally call through so many numbers to make sure that we were doing this. We had spent over an hour on hold with our insurance provider just to see what was covered. So that has not been effectively communicated to us. So I really want to harp on this, that we need to do better. With that being said, I did mention choice. We are going to get an influx of people coming for services, for abortion services. And I know that that is going to draw a lot of attention. At the same time, we are dealing with the pregnancy service centers or the crisis prevention centers, which we all know are just fraudulent abortion clinics. I said what I said. Their deceptive practices hurt our communities, specifically Black and brown communities like mine. And so what are we doing? What is the administration doing in looking forward to not only limiting them, but exposing this dangerous practice that they have? And also, once again, going back to our communities, making sure that we're outreaching, right? Performing the proper awareness outreach to our communities, but more importantly, communication in different languages as well. And who do you think would be the best partners? Have you worked with? Which CBOs have you worked with? And how do we go through that? So I know those are a lot, but this is something I'm really passionate about because we should not defraud folks who are seeking care.
Thank you so much for that, Councilmember. And again, we are so thankful that in New York, abortion is legal. And your point about communication campaigns in particular, we're very aligned with you on that. We see that as a critical strategy and agree that it has to be in multiple languages. And we also acknowledge that there will be a hearing about this on Friday where we can go in even more depth. But I'm going to pass to my colleague Laura Lewison to share more about what we're doing on crisis prevention centers.
Thank you, Dr. Morse. And Councilmember, I share your anger. These are really better called fake clinics because they intentionally imitate health clinics by using names and banners and signs that look similar to real clinics. And they often offer low-cost resources like baby clothes and diapers, but they do not provide abortions. And they intentionally mislead people who can be seeking abortion care. We look forward to working with DCWP in collaboration on your bill. And I also want to note that we have recently spent a lot of work updating our website to make sure that New Yorkers have access to accurate information about abortion. That website includes information about how to determine whether a clinic is a fake clinic and how to report someone who may be misleading a patient.
That is huge, and I appreciate that. And I look forward to making sure that we really do provide all aspects of information in care. The last follow-up, and chairs, if you allow me to ask this, security for the abortion clinics, how are we going about that, and what are we looking forward to that?
Thank you, and I really appreciate you raising this issue because we know that abortion is legal in New York City and it is safe, and that we have seen increased protester presence at the healthcare facilities that provide abortions throughout the 5 boroughs. And that patients, in order to uphold our commitment to safe and legal abortion, we need to ensure that patients are not harassed or intimidated
when they are entering a clinic, and that is also true for providers. Provider and patient safety is critical. We know that the State Department of Health has also increased funding for security at clinics, and that's going to be a critical aspect of our strategy to ensure safety. We also look forward to working with NYPD to ensure that those who intimidate or harass or attempt to prevent people from accessing abortion services are removed and prosecuted.
Okay, thank you. I just have a couple more questions, and then I'll turn to Chair Narcisse to see if she has more, and then we'll open it up to the public. So I want to know, what resources does a pregnant person have if they don't feel they know how to navigate the medical system or experience complications and don't feel they're being heard? Because I've seen it happen personally and experienced it, and in our public hospital system. So that's the question I want to get answered.
Thank you, Chairperson, for that question. And we're aligned with you very much about the need to make sure that patients and pregnant people in particular have the support they need to navigate our complex health system. In fact, that is one of the key challenges here, because most of our hospital systems are not actually formally connected. It can be even more challenging for pregnant people to navigate them. At the same time, we do think that our new family home visit initiative actually is one of the ways that can help patients and pregnant people navigate the health system. And our doula services similarly are really intended to support and accompany pregnant people through what is unfortunately a fragmented and complex system, and one in which cost is also often not transparent as well. I do want to give the opportunity if Laura Lewison or Dr. Allen want to add to that.
So your question is resources for patients who find themselves lost in the system.
Also, patients that feel they're not being heard when they're in the hospital.
So what we do have posted throughout all of our facilities are the Patient's Bill of Rights. We've been working with DOH-MH in a collaboration around respectful care, publicizing with pamphlets just what the patient should expect, what they're due. Respectful care is a human right. We also have patient advocates within the hospitals, which are available to the patients, where the patients can go and express their disappointment or complaints as well. And on our website, we've been working on our website so that there is information there to hopefully help a patient navigate if they want to find a specific doctor or if they want to find a specific service. That is a work in progress, which we're building currently.
Thank you. Now I'm going to ask just one set of questions, and then I'll be complete. So I want to know, and this is a little controversial, does the city collect hospital-level maternal health data at each hospital, and is this something that can be shared with the council? We understand there may be HIPAA concerns, but that's my question.
Thank you for the question. We are really aligned in the intent of making sure that data is used to drive decisions and programs, and certainly also our health equity work in particular. We, as you described, because of confidentiality for patients in particular, and because of the small number of maternal deaths every year, we aren't able to share information at a more kind of precise level because of concerns about confidentiality.
So even if the data is not public, what is being done if there's a trend of deaths or morbidity at a particular hospital? What is it that you do to make sure that there's accountability and measures put in place for that not to happen again?
Thank you again for that question, and we are aligned with you around accountability. One of the programs that really does help to advance that is the Maternity Hospital Quality Improvement Network. And that network really uses quality improvement methodology and strategies to work with hospitals to make more immediate improvements and to prevent severe maternal morbidity and mortality. And it is also very exciting that we are, over the coming months, going to be able to expand the Maternal Hospital Quality Improvement Network. The original cohort was 14 hospitals, and we're going to be offering membership into the cohort, into the Maternal Hospital Quality Improvement Network to all 38 hospitals that do deliveries over the coming months to years. So we're excited about that expansion as well. And I'm going to pass to Dr. Allen.
In terms of quality and looking internally at our quality, we do report our morbidity and mortality to the state through our regional perinatal center. We've also engaged ACOG, the American College of Obstetrics and Gynecology. They have a voluntary quality review committee, and they have started actually coming into each of our labor and delivery suites to do an objective evaluation of the quality of our services.
Okay, thank you very much. Councilmember Rivera has some questions. She just joined us again. Thank you.
Thank you so much.
Oh, and we're going to try, we're asking all the council members to please keep to the time. Thank you.
Absolutely. Thank you for conflict in hearings here. So thank you so much for your testimony. Thank you for being here. I really do appreciate you answering all of our questions. Some related to my bills in the package. One of them calls for the council to support state legislation mandating that all maternity patients receive culturally competent notices of the risks associated with C-sections. I know you covered a little bit of that today. But how does H&H currently communicate the risks of C-sections to pregnant people in New York City? What are the current rates? Do you have this data available by demographic? How many do you estimate are emergency C-sections? And how do you, we'll stop there actually.
Thank you, Councilmember Rivera, for that phenomenal question. We one thing that I do want to share before I pass it to Dr. Allen to share more about the rates and the work that Health and Hospitals is doing in this realm. We do have a coalition to end racism in clinical algorithms that the Health Department launched last fall. And one of the algorithms that we've been looking at is specifically how race is used in determining risk for vaginal birth after cesarean section. And we're honored to partner with Health and Hospitals. Health and Hospitals is a member of that coalition, and Health and Hospitals has been looking very closely at how that algorithm could be de-implemented, which we do see as one of the ways to address unnecessary cesarean section rates. I'm going to pass to Dr. Allen to speak more about Health and Hospitals' work.
So your specific question, demic outcomes by race and ethnicity, I don't have that for you. I do have our rates for cesarean sections and how they compare to the city and the state. We do educate each patient on an individual basis. If someone needs a cesarean section, it's an individual conversation of the risk and benefits, and of course with informed consent. Currently, our overall cesarean section rate is 20%. This is the primary cesarean section rate for a woman at term with a singleton who has her first cesarean section. And it's well below the healthy people 2030 target of 23.6%. The total cesarean delivery rate for New York City Health and Hospitals is 33%, which is consistent with the city and state rates across the board. We work very hard to avoid unnecessary cesarean sections. We do not do cesarean sections that are not indicated clinically. And for the acuity of our patient population, as I said, our overall cesarean section rate of 33% is about normal. Our primary cesarean section rate is lower than the city and state numbers.
How do you collect and evaluate key maternal safety data for hypertension, hemorrhage, infections, and C-section rates? And every hospital should have a systematic approach to reviewing maternal health complications acting on the data as appropriate, and implementing improvement strategies. So how does the data inform patient communication regarding the C-sections?
So we do collect the data, as I said, and report it to the state through our regional perinatal center.
And on some of the things I specifically mentioned, right? Hypertension, hemorrhage, infections.
Yeah, the medical complications, and it's part of, the CDC has started this SMM, severe maternal morbidity, which is collecting data on your rates of hypertension and how diabetes and other medical conditions. So we're collecting that data. We don't have a systematic process of sharing our dashboards with our patients, but we do, as I said, have the individual conversations with every woman who has a cesarean section. These are the risks in general. These are your personal risks based on your medical condition that you're presenting now.
And my last question is, so I have another piece of legislation to take action so the doula community is explicitly and thoughtfully included in navigating making doula services more accessible to individuals with Medicaid and those without health insurance. I know we don't want to repeat the 2018 pilot program that failed to adequately compensate doulas for their expertise and time. I think you've seen a survey regarding doula care in New York City. 72% of women reported that their doula helped them communicate their preference and needs, but 80% of this cohort reported that cost was prohibitive when opting to work with a doula. So does the administration support the urgent need for state legislation to work in collaboration with doulas? And how does Health and Hospitals collaborate with birth workers to improve patient experiences and outcomes? Thank you.
Thank you, Council Member. And just before we answer that question, I did want to highlight, and Dr. Stein was just reminding us of the data. We do actually publish annual data on cesarean section rates as well on our health department website. And so just wanted to mention that resource. In terms of doulas, we are aligned with you. We would never want cost to be a barrier to a pregnant person who's interested in receiving the support and services of a doula. In fact, our citywide doula initiative allows for, or I should say, provides access to doula services for free. And we're excited to continue to enroll more and more families in that program. We're happy to share with Council the specific information for people across New York City who are interested in access to that program, and we actually do prioritize the communities that have the highest rates of poverty for enrollment in the citywide doula initiative. And I'll pass it to Dr. Allen to answer the Health and Hospital specific question.
So we do not hire doulas ourselves, and I think if the New York State legislation, with your support, comes to a conclusion of how to compensate doulas for their work, it would be a tremendous advantage to us. What we do is work with the community-based organizations and the community doula services, and we actively refer our patients to those organizations like Ancient Song and By My Side and the Caribbean's Women's Service. But totally aligned with you that this is an important service, needs to be compensated properly. The commercial carriers as well as Medicaid should participate in that compensation so we can more actively engage the doulas appropriately.
Thank you very much. I'm going to ask Chair Narcisse if she has any remaining questions.
I'm gonna yield to the advocates because I want to hear from them. But before I leave, I want to talk about advocacy group that working so hard about language access and cultural competency is very important. Just keep that in mind, and you don't have to answer that. But I know you have it in mind. But I just want to know that I say it, so don't forget that part, because a lot of folks will come to the hospital because of language. They cannot get the care they deserve. So I want to say thank you for your time, and I appreciate you being here. So I'm looking forward to listen to the advocate, I guess. Thank you.
Thank you very much to the administration for being here today. We really appreciate it. And if you have somebody that can stay to hear the advocates, that would be great. Thank you.
Thank you, Chair, and thank you to the administration for their testimony. At this time, we've concluded administration testimony. We'll be moving on to public testimony. We'll be calling on individuals who are here in person and on Zoom, on the Zoom webinar as well. Our first panel will be Lorraine Ryan from the Greater New York Health Association. You may begin your testimony as soon as you're ready.
Okay, sorry about that. I was having trouble getting off mute. Good afternoon at this point, and thank you for allowing Greater New York to participate in this hearing today. I do realize that time is short, so I'm going to really abbreviate my remarks and hopefully address some of the issues that were already raised this morning, and very well raised, asked, and answered. I just want to thank Chair Shulman, Narcisse, and members of the committee for allowing me to participate. I'm a senior vice president at the Greater New York Hospital Association, working in the clinical regulatory and quality improvement division, and I'm also a registered nurse. I don't need to repeat all that we know about the studies and that Black and Brown people suffer disparities with regard to outcomes of care with regard to pregnancy and actually pre-pregnancy health as well as postpartum care. In recognizing those disparities, both the New York State Department of Health, the American College of Obstetricians and Gynecologists, District 2, New York, Greater New York, and others have been actively engaged for many years in different types of supportive programming and improvement efforts. And despite those efforts, these disparities persist. We have seen somewhat of a drop in mortality in Black and Brown populations. More recently, however, it's really not where we need to be, and we have a lot more work to do. I want to point out a few of the challenges that our hospitals do face, knowing that hospitals are the biggest providers of perinatal, prenatal, and postpartum care, as well as delivery services, as you know. And this is particularly true for Medicaid beneficiaries and the uninsured. And hospitals face significant challenges with this with regard to the inadequacy of the Medicaid rate and the ability to properly expand these services as needed across their systems. We have 30 hospitals across the state on the watch list for closure, primarily in high-need New York City areas. And at any one time, 7 to 10 of those are in the New York City area. This is very concerning, and yet it persists. We have been able to, with 1199, successfully achieve a 1% Medicaid rate increase in this year's state budget. This will help, but this is clearly not enough. There are lots of insurance gaps. I won't get into that with you today, but it is in my prepared testimony, written testimony that you have. I do want to point out to our gratitude to the legislature for passing the postpartum coverage up to 1 year for pregnant people. We think this goes a long way of ensuring that that one post-delivery visit happens. Right now, only 40% of birthing people, many of them Medicaid beneficiaries or uninsured, do attend a postpartum checkup, and I know that was raised earlier today. We believe that expanding postpartum coverage will improve the long-term health and well-being of not only the patient, but the family. There was commentary earlier today about pre-pregnancy wellness. We believe that is essential, and we have worked with primary care providers to identify for them the things that they should be looking at and looking for in their patients once they become able to become pregnant and to conceive, and ensure that that patient, if they have underlying medical conditions, are already that they are under control. There's a lot been said on the social determinants of health, and we know that in hospital care, pre-pregnancy, prenatally, postpartum is not enough. It's what we do for patients in the community with regard to housing, education, transportation, and employment. And the four walls of the hospital setting alone cannot guarantee the best outcomes. And just lastly, on insurance, medical liability reform is essential in New York State right now. It is driving obstetricians from our state. And again, our safety net hospitals are those who are most impacted, who cannot adequately recruit and retain these essential providers. There are a number of improvement initiatives that have been going on. Greater New York has been a part of many, if not all of the ones I'm going to mention, or I should say they have been a part of all the ones I'm going to mention. But clearly, we still need to do more. We have had clinical improvement projects focused on hemorrhage, preparation and response to hemorrhage, identifying the risks of hemorrhage in different populations, venous thromboembolism, which is a leading cause of death in patients postpartum, and ensuring that patients know what to look for on discharge from the hospital, and many others. We participated and helped implement a maternal depression screening collaborative in the New York City region with the assistance of the New York State Department, the City Department of Health and Mental Hygiene. That was very successful, and we were seeing this screening continue and to be very effective in identifying either early on in a pregnancy or in the postpartum phase, signs and symptoms of the lack of mental well-being and referral. Significantly, however, where referring is not easy, it's always a challenge, and finding providers to assist with that ongoing care is something that we need to focus on. I do want to mention the Birth Equity Improvement Program. We talked a lot, I've heard a lot about implicit bias training, and that is excellent. And in the 2018 state budget, there was a certain amount of money put forward for a number of initiatives, including implicit bias training. However, the Department of Health is using that funding in what we all think is a very meaningful way, which is this Birth Equity Improvement Program, which gets at disparities, and the measures include the patient's reported experience of care. It gets at the voice of the patient, how they see themselves in the eye of the medical providers, what isn't happening for those patients. And we think that this is a really important program that should be sustained beyond the life of even the state's support. We believe this is something hospitals can do. Very importantly, they're collecting race, ethnicity, and language data. They're reviewing those prenatal data stratified by race and ethnicity and language. There are anti-racism components. The measures include a patient-reported experience measure, how they experience that institution and those providers, as well as a goal of reducing C-section rates among Black patients by 5%. And this would be in the lowest risk population for any risks to having a C-section. There are other initiatives that are ongoing, as well as hopefully you've all seen the first New York State Department of Health maternal mortality report that was issued in April, which outlines in great detail the findings in those reports in terms of what was pregnancy associated versus pregnancy related, the leading causes of death in that report, which are embolism, hemorrhage, and mental health issues. And also defines a set of approaches to improvement, which have not yet been put into place, but hopefully with the right support and funding will be in the future, so that we find ourselves in a much better state in New York than we are today with regard to outcomes of care. I had to rush through that, and I apologize for stumbling a bit, but I thank you for the opportunity to participate today on this critically important issue. Our members are committed to working with the city, the state, and federal government, which is also very well focused on this initiative in this current administration, and other providers across the state to improve. If I could, there was a lot mentioned around doula, and I do want you to know that during the pandemic, we were very helpful in ensuring that doulas had their access to their patients in hospitals. And the question came up earlier, did a doula supplant, if you will, or replace the patient partner? And the doula did not. The state rules around this during the pandemic were to allow both a partner and a doula access because of the importance of doulas to those patients. And we very much believe in how doulas and midwives can be very, very instrumental in improving outcomes going forward. And we're currently working with the City Department of Health and Mental Hygiene, Maternal and Infant Reproductive Health Group on looking at doula compensation. We know that the pilot failed downstate because of an inadequate rate for doulas to have a living wage, if you will. And we have been working with the state's Office of Health Insurance Programs, looking at how that can be addressed. And also that the pipeline of doulas is available to the New York City boroughs and those boroughs that we know are most in need. Thank you very much. I have a lot more to say, but with limited time, I will hold that for now. And you do have my written testimony. Thank you.
Thank you so much for your testimony. We'll now be moving on to our next public panel. which is Brooklyn Borough President Reynoso, followed by Janet Peguero from the Deputy Bronx Borough President. Borough President Reynoso, you may begin as soon as you're ready.
Time starts
Thank you
now.
so much. Thank you so much. I want to say hi to this amazing panel of amazing women and from all of the boroughs, especially the ones from Brooklyn. But I just want to say thank you all for having this important hearing. As you know, I've made it my mission this year to focus on maternal health and have invested significant amounts of resources to our public hospital systems in Brooklyn to ensure that we lower the mortality rate for Black women. What we've been able to accomplish is about $15 million per hospital in Brooklyn, Woodhull Hospital, Kings County Hospital, and Coney Island Hospital, in an effort to have infrastructure that speaks to the type of standard of care that we want Black and brown women to receive in our borough. We're hoping to make Brooklyn the safest place for all women to have babies within 4 years, and hopefully within 8, Brooklyn the safest place in all of the country for women to have babies. And it's not an easy task because the infrastructure is one part of a bigger problem that we have when it comes to maternal mortality. I will work the best I can on those type of resources, but want to just talk to this committee about 2 issues that I think are extremely important. One is the midwifery programs within the health and hospital system. Many hospitals within H&H have midwives in their program, but the work is not centered around midwives. Doctors and surgeons still run the show, and midwives are looked at as secondary or B-level players within the birthing experience for Black women. So I want to change that and make sure that the executives in these hospitals and the H&H at the top level ensures that midwives run the show. They are actually the people that are making the decisions for these women. Should we do that, I think that we will see a significant drop in the cesarean rates and the maternal mortality in our city. I also want to talk about wait times. Many of the poor population here in the city of New York go to public hospitals because of its affordability and accessibility, which is a great thing. But we're hearing about 2, 3, 4, and in some cases more than 4 hours of wait time to see doctors, which means people have to take off an entire day of work or have to commit to a whole day of to be able to see a midwife or a doctor or anyone that's providing care. It's extremely concerning because in a private hospital, these things can happen in 30 minutes to an hour. And just that wait time alone, I think discourages people from continuing to go back or from having to continue to take time off from work. So I just wanted to make sure that we brought both of those issues up. So again, I'll be focused on working on the infrastructure work and the marketing to educate and inform birthing people of the risks and how they can better prepare themselves to have babies. But when it comes to the work that needs to be done at the leadership level within these hospitals, I want to task and hope that my colleagues within the City Council can really hold the health and hospitals to task. I want to thank you all for taking on this very incredibly important issue and see me as an ally. Just very quickly, a little bit of the background as to why this is so important to me. My wife had 2 babies in a public hospital. I wasn't aware or aware enough of the dangers that this birth or these births were posing on my wife. I felt helpless as a council member, a person that has some influence and power to affect any change, to put my wife in a position to not be 9.4 times more likely to die than her white counterpart. And I couldn't do anything about it. But now as the borough president, I really feel that I can affect change, and is why I'm investing all of my resources in the capital side this year on this type of work. So again, thank you to everyone working on this. Please see me as an ally, and just want to make sure everyone spreads love. It's the Brooklyn way. Thank you so much.
Thank you so much for your testimony. I'd like to now turn it to Janet Peguero, Deputy Bronx Borough President.
Thank you, Chair Shulman. And thank you, members of the committee. It's a pleasure to be here today. 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 It's a pleasure to be here Good afternoon, and thank you, Chairperson Schulman, Chairperson Narcisse, and members of the New York City Council Committee on Health and Hospitals for the opportunity to speak on today's package of bills relating to combating the high rates of maternal mortality and morbidity in our city and providing access to reproductive care. My name is Janet Peguero, and I'm the Deputy Bronx Borough President, and I'm here to provide testimony on behalf of our Bronx Borough President, Vanessa L. Gibson. Thank you all as a collective for being intentional when drafting each and every introduction and resolution. At a time in which we are seeing an unprecedented attack on our reproductive freedom, it is imperative that our legislators on the city and state levels take immediate action to protect women and birthing individuals. The Borough President was proud to introduce Intro 0086 alongside Public Advocate Jumani Williams to improve outreach and education regarding the standards for respectable care at birth and other information that will improve the birthing experience for women in our city. It is clear that this healthcare crisis is rooted solely on the color of the birthing person's skin, and there is a direct target on the lives of Black and brown women in the city of New York. Additionally, the Borough President is in support of these bills as they will strengthen and expand and provide the necessary resources we need to save lives in our borough and across the city of New York. The administration today addressed the current doula services. However, the current city services are burdensome to our doulas and birthing workers who are already severely underpaid via public reimbursement. The mayor announced a plan to expand doula access, and though it is a start, it is not nearly enough. Training 50 doulas to help 500 families in 3 months is not feasible. And although we are grateful for the service providers, none of them are based in the Bronx, which is why many of our on-the-ground grassroots organizations and advocates are delivering direct services to birthing persons on the ground uniquely in unique and creative ways, and still without the support or funding from the city of New York. The onus is not on our doulas to make up for the work that the city has neglected. It is up to us, the legislators. That is why the Borough President is in support of these bills. Despite our borough being one of the epicenters of maternal mortality in the state of New York, we have limited resources to address these issues and are in dire need of a birthing center in our borough. This is why we initially created the Bronx Maternal Health Consortium, which emerged from the Black Maternal Mortality Task Force with the purpose to effect change through public policy and borough-wide community activism. This is very much aligned with what we are discussing here today. As you all know, according to the 2020 CDC data, Black women in the city of New York were 3 times likelier to die from maternal causes as white or Hispanic women, and each year the death count rises. This striking disparity persists and highlights the need of Intro 0409, a local law that will increase access to data and maternal mortality and morbidity. Again, the administration refused to share data while asked by the chairperson this morning. Again, the state of New York lags behind other states when it comes to funding doula services through Medicaid. As of December 2021, 17 states were offering or are on the path of providing statewide doula coverage through Medicaid. The BP strongly supports Resolution 0205, calling on the state legislature to make doulas more accessible to individuals with Medicaid as well as those without health insurance. New York should extend doula coverage statewide on a permanent basis and increase the reimbursement rate to match our peer states like New Jersey, Virginia, and California. New York is at a historic moment with a female leadership team at Bronx Borough Hall, the New York City Council, and on the state level. Now more than ever, with the ruling of Roe v. Wade, we need stronger legislation on the local level to support women and lead this progressive national effort to ensure that the standards of respectable care at birth become universal. As a collective, these bills will help tackle the racial disparities in adverse maternal outcomes. The more we wait, the more women and birthing persons we will lose. You all have been valuable partners in combating maternal mortality and severe morbidity. The Bronx Borough President strongly commends you all for the shared commitment and strongly endorses each and every bill. She strongly wants to thank each and every advocate. Your leadership has saved lives and has grown our communities in the borough of the Bronx. Thank you.
Thank you so much for your testimony. We'll now be moving on to our next public panel. In order, I'll be calling on Paige Bellenbaum, followed by Patricia Loftman, followed by Teresa Ginger. In the meantime, if you are here for the Women and Gender Equity hearing on childcare, that's taking place next door in the committee room. This is the Health and Hospitals hearing on maternal health, mortality, and morbidity. Thank you. All right, you can get started.
Members of the Health Committee and Committee of Hospitals, thank you for the opportunity to testify here with you today. My name is Paige Bellenbaum, and I am the founding director of a maternal mental health clinic called the Motherhood Center. Opened in 2017 by reproductive psychiatrist and founder of the Payne Whitney Women's Clinic at Weill Cornell, Dr. Catherine Berndorf, and myself, the Motherhood Center provides support and psychiatric clinical treatment to new and expecting mothers and birthing parents experiencing perinatal mood and anxiety disorders, PMADS, otherwise known as postpartum depression. We have since become a leading maternal mental health facility in New York City and nationwide, and New York State's only Article 31 perinatal partial hospitalization program. We also provide PMAD education and training to the medical community and outpatient therapy and medication management. Over the past 5 years, we've treated thousands of perinatal women in New York City struggling with PMADs. As a result, we have also saved thousands of lives. Perinatal mood and anxiety disorders, including perinatal during pregnancy and postpartum depression, anxiety, obsessive compulsive disorder, post-traumatic stress disorder, bipolar disorder, and in rare but life-threatening instances, postpartum psychosis. 1 in 5 new and expecting mothers experience a PMAD, but those of us that do this work know it's more like 1 in 3. Since the pandemic, global studies have found PMAD rates to be as high as 72%. Tragically, overturning Roe v. Wade will increase maternal mental illness even further. Though hormonal changes during pregnancy and the postpartum period can cause mood and anxiety disorders to surface, PMADs are not exclusively driven by neurochemical causes. Other key factors, including racism and low socioeconomic status, can increase the risk and severity. These external stressors can have significant effects on pregnancy, maternal health, and child's development. Black, Indigenous, and other people of color and those with low incomes experiencing postpartum depression at significantly higher rates. Studies show more than half of infants in low-income households live with a mother experiencing depression. New mothers of color have rates of postpartum depression close to 38%, almost twice the rate of white new mothers. Nearly 60% of Black and Latinx mothers receive no treatment or support services for prenatal and postpartum mental health. Reasons include lack of available perinatally focused treatment, insurance coverage, social and cultural stigma related to mental health needs, logistical barriers to services, and lack of culturally appropriate care. Sadly, 80% of all PMAD cases go undiagnosed and untreated due to the enormous shame and stigma that surrounds maternal mental health. For many new mothers, their greatest fear is that their child will be taken away if they tell anyone how they really feel and that they will be deemed an unfit mother. This is why screening alone is not sufficient. PMADs are the #1 complication associated with childbirth in this country, far surpassing the rates of hypertension and gestational diabetes. PMADs are also one of the leading causes of maternal mortality in the US. Yet despite these startling statistics, PMADs receive little to no mention in conversations and policies pertaining to maternal health outcomes. And PMADs are totally treatable. Today you have a set of essential bills in front of you that will improve birth outcomes and increase accessibility to reproductive supports and workplace protections. Yet rarely, if at all, is there mention of maternal mental health. I am here today in support of these bills, but I would be remiss if I did not say, shame on us as a city for neglecting the mental health needs of new and expecting mothers and birthing parents. I would venture to believe that every single person in this room either knows someone who has suffered from postpartum depression or experienced it themselves. Perhaps you or someone close to you struggled with feelings of hopelessness, helplessness, dread, shame, guilt, overwhelm, scary, intrusive thoughts of harm coming to the baby, a sense of regret, loneliness, isolation, rage, feeling as though having a baby was a huge mistake, longing for life before becoming a mother, feeling trapped and exhausted and unable to sleep or eat. Perhaps even thinking, I don't want to live anymore. This is too much. My family would be better off without me. and because the shame and stigma that surrounds maternal mental health are so great, because we live in a society that glamorizes and romanticizes motherhood, presents it as the most blissful and amazing thing that will ever happen to a woman, the new or expecting mother can feel like a failure if she experiences anything but, and she becomes one of the 80% who suffer silently. I was one of those mothers. 16 years ago, I gave birth to a beautiful, healthy baby boy. A few weeks after he was born, I began feeling severely depressed and anxious. I couldn't take care of myself or my son. I couldn't sleep, eat, or function. I was miserable and I didn't want to be alive anymore. I felt alone and ashamed, and I hated myself for being such a failure at the one thing I was supposed to know how to do. I kept all of this to myself for 9 months until one day I decided I couldn't carry on and that my family would be better off without me. I am fortunate to be sitting here in front of you today. But according to data released by the New York City DOHMH Maternal Mortality and Morbidity Review Committee, of which I am proudly a member, mental health conditions cause 18% of pregnancy-associated deaths in 2016 to 2017. This is 16 of the 91 deaths that year, and all but one were deemed potentially preventable, most with some chance of altering the outcome. These women were not as lucky as I was. A review of 14 state maternal mortality review committees from 2008 to 17, among 421 pregnant-related deaths, 11% were due to mental health conditions. Pregnancy-related health deaths were more likely than deaths from other causes to be determined as preventable, 100% versus 64%. According to a recent Surgeon General's report, maternal mental health disorders contribute to the U.S.'s high maternal mortality rate and impact mother-infant bonding and infant development. The report states each year more than 20% of U.S. women experience a mental, behavioral, or emotional disorder such as depression or anxiety. Mental health conditions are also common complications during pregnancy and postpartum and contribute to poor maternal health outcomes. Mental health conditions are underlying factors in injury or death due to overdose or suicide. Mental health conditions in the postpartum period, such as postpartum depression, are associated with poor maternal and infant bonding, decreased breastfeeding, initiation, and delayed infant development. And let's talk more about the impacts of untreated PMADs on mothers and babies. Rigorous systemic reviews have found that untreated PMADs cause a whole host of adverse impacts on both mother and baby. According to one meta-analysis, women experiencing depression or anxiety during pregnancy are 40% more likely to have hypertension than those who do not. Women with untreated bipolar disorder are more likely to experience adverse pregnancy outcomes, such as gestational hypertension and hemorrhaging, and are nearly twice as likely to have a preterm birth compared to women without mental health challenges. Pregnant women with untreated anxiety have higher risk of preterm birth and lower birth weight, and their infants have higher risk of being small for gestational age. And children, as they grow older, of women with untreated postpartum depression can experience long-term impacts on their health, mental health, motor development, cognitive and emotional development. Undiagnosed and untreated psychiatric disorders such as depression are a risk factor for suicide in new mothers, a leading cause of maternal mortality in the United States. New York City can and must do a better job in addressing the mental health needs of new and expecting mothers and birthing parents. The Motherhood Center is thankful to have joined forces with DOHMH and the Bureau of Maternal, Infant, and Reproductive Health on efforts to educate and train the MHQIN network on PMADs. We collaborate with Nurse Family Partnership by offering maternal mental health client consultation and provide support groups for NFP clients struggling with PMADs. But still, there is so much more that needs to be done. We can look to other states and localities that have embarked on government-led initiatives that have significantly impacted PMAD rates. Some of these initiatives for New York City could include establishing a maternal mental health task force, responsible for identifying the scope of PMADs locally and devising policy and practice recommendations, initiating a citywide PMAD public awareness campaign aimed at defeating the stigma surrounding maternal mental health, normalizing the challenges parts of becoming a mother, communicating basic PMAD symptoms, and providing support and treatment resources. initiating a citywide PMAD education and screening initiative, training hospitals, behavioral health clinics, OBGYNs, and pediatric offices across the city on what PMADs are and how to routinely screen with appropriate instruments and dialogue. An attempt was made at this effort 5 years ago as a part of Thrive NYC, but it somehow evaporated. Most importantly, offering enhanced specialized PMAD treatment, investing in effective and affordable maternal mental health treatment programs specifically for low-income women, and training behavioral health clinicians and other municipal mental health providers on PMAD best clinical practices. We can and must do better, including maternal mental health in conversations and policies that strive to improve maternal health outcomes will save lives. Thank you again for the opportunity to testify today.
I want to thank you for that testimony, and we will keep PMAD in mind as we move forward.
Thank you.
Good afternoon, Chairperson Schulman and Chairperson Narcisse. Thank you for this opportunity to provide testimony. My name is Patricia Loftman. I'm a certified nurse midwife, and I am providing testimony on behalf of and represent New York Midwives as the Black, Indigenous, People of Color representative. New York Midwives is the professional organization that represents certified nurse midwives and certified midwives. I am currently a member of the New York City Department of Health and Mental Hygiene, Maternal Mortality and Morbidity Review Committee, and I am a member of the Health Equity Work Group of the Advisory Committee on Infant and Maternal Morbidity and Mortality, which makes recommendations to the Secretary of Health and Human Service. In the service of time, I'm going to abbreviate my comments since you do have my written testimony in front of you. So what I will do is highlight what I think are the most important parts of my testimony. I respect that these legislations are the work product of individuals who have the best intentions and whose goal is to improve the health status and decrease the maternal morbidity and mortality of Black women and reproductive age persons. However, I think it's really important that we evaluate what the impact of these legislations will be. The medical and public health community have accepted the thesis that institutional racism generates racial and ethnic health disparities. Racism is the power to control the distribution of necessary resources, guaranteeing equal access to the systems that affect all phases of one's life: political, economic, social, and health. In an ideal world, racism would not exist. In an ideal world, everyone would have impartial and unimpeded access to effective political representation, decent housing in safe neighborhoods, quality education with access to gifted and talented education and specialized high schools, employment opportunity with a living wage, merit-based compensation, and quality health care. Health disparities in racial and ethnic communities would disappear if racism did not exist. Today, words such as institutional and structural racism, health equity, diversity and inclusion, birth equity, reproductive justice, and social justice have become such an integral part of our daily language that they no longer elicit the sting and bite that they once had. Legislators and policymakers are quick to lament that we can't undo racism, but racism must be dismantled. Legislation and healthcare alone cannot alleviate or mitigate the dire consequences that racism was and remains embedded in the foundation systems that continues to affect the daily lives of Black, brown, and indigenous communities. So what I did was I looked at all the proposed legislations, and I grouped them based on similar or identical language. And what I noted was that many of the proposed legislations either already exist somewhere, or they're very, very similar in other languages. So what I did was I grouped them together based on similarities. And the first group have to do with the education about city standards for respectful care at birth, health proxy forms, and patients' rights. There currently exists a pamphlet titled New York Standards for Respectful Birth at Care. This pamphlet discusses education, informed consent, decision-making, quality of care, support persons, and dignity and non-discrimination. While it does not address workplace accommodations for breastfeeding, disability insurance, or paid sick leave, the pamphlet can be corrected and updated to include these topics. Nurses are among the largest group of educators, yet they are missing from the list of providers and should be added to the list of persons providing education. Additionally, while doulas provide a valuable service to Black women and reproductive age persons, they are not clinical providers, which might be confusing to the public, so this information should also be corrected. Additionally, it would be helpful to explicitly state the scope of practice of all care providers listed. An additional problem, however, is that while this document exists, there does not appear to be monitoring, oversight, or enforcement within the institutions. The next one has to do with increasing access to maternal mortality and morbidity data. So as was previously described, the Maternal Morbidity and Mortality Review Committee was formed in 2018, and of course the purpose is to reduce preventable maternal mortality in New York City and to eliminate inequities. The report, the most recent report was published in October of 2021, so it's up to date and it's available. So if the goal is to decrease maternal morbidity and mortality, the public deserves to know the identity of the hospitals where maternal deaths occur, and this information should be reported yearly. Additionally, currently exists a pamphlet titled Maternity Information Childbirth Services, which provides information about childbirth practices and procedures in all hospitals in New York State, including cesarean birth rates, vaginal birth rates after cesarean, episiotomy rates, and other statistics birthing people should rightfully have access to. Hospitals are required to forward the data to the New York State Department of Health. The New York State Department of Health then compiles the data, which is then published and becomes the Maternity Information Childbirth Services pamphlet. The New York State Department of Health distributes the pamphlet to the hospitals. The hospitals are supposed to then distribute the pamphlet to women and reproductive age persons seeking care. The value of obtaining this pamphlet is that receiving this information empowers Black women and reproductive age persons with the information that they need to make an informed choice about the site where they choose to receive services. The problem is that few legislators, policymakers, hospitals, or even the public is aware that this document exists. There's no accountability or enforcement placed on hospitals to forward this legally required data to New York State Department of Health. Choice increases birth equity, and birth equity decreases maternal morbidity and mortality. Consequently, the New York City Department of Health and Mental Hygiene, as a recommendation, should be mandated to protect Black women and reproductive age persons by generating the New York City Maternity Information Childbirth Services with an enforcement process rather than relying on a state process that apparently does not currently appear to be working. Another legislation talks about training doulas to provide doula services in all 5 boroughs. There currently exists a very detailed report that was created in 2021, just a year ago, and can be accessed. I have provided the citation. The report outlines in detail the challenges in providing women and birthing people with doula care in New York City. The report also identifies doula programs that have completed their initiatives, are ongoing, at risk, or off track. Another proposed legislation talks about the benefits of services provided by doulas and midwives. The public is currently unaware that midwives are available and accessible in many hospitals throughout New York City. And so as a recommendation, I think it would be very, very helpful if a public service campaign either through the New York City Department of Health or DOH-MH about the fact that midwives are available and accessible in hospitals throughout New York City. You know, I was on the train this morning, and in one of the cars, the entire car was plastered with information about cannabis. So my a recommendation would be that such a public service campaign be conducted in terms of providing information to the public about midwives, doulas, and the benefits that they serve. There was another proposed legislation about an outreach campaign on the risks of cesarean sections. New York State Assembly member Amy Paulin has introduced 2 bills to address cesarean birth. The first talks about informing women about the risks associated with cesarean birth, and the second establishes a cesarean birth review board to improve cesarean birth rates and outcomes. I think the overarching theme is that a lot of what these legislations, the proposed legislations, are designed to do either already exists in some form, however lack enforcement, monitoring, and accountability, or exists at another level at the state, and maybe the resources of both city and state should be blended. So I think what I'd like to then talk about is some recommendations. And I've broken them down into 2. One is policy, and then the other is service delivery. I think we need to rethink how data is captured. Currently, data is obtained from institutions via monthly report. Data is also extracted from the maternal morbidity and mortality report. However, missing are the voices of the women and reproductive age persons who utilize the services and who are most affected by the care that they receive. They have the answers. Create health delivery systems based on what the women want, not what policymakers think they should receive. What is the perception of the women and reproductive age persons? What is their perception of the quality of the primary and reproductive care that they have received? Women and reproductive age persons want respectful care based on a relationship. Black, brown, and indigenous women reported that the perinatal care system currently available to them does not provide them access to care by the provider of their choice. They report that the ideal system would have more access to care by midwives, a midwife or doctor who shares their heritage, race, ethnic, or cultural background, a provider with whom they can develop a trusting relationship, a doctor or provider who is a good match for what they value and want for pregnancy and birth care, continuity of care throughout pregnancy and birth, shared decision-making, a pregnancy and birth free of mistreatment, a pregnancy and birth characterized by respect, privacy, and dignity, a pregnancy free of pressure to accept interventions and procedures. Also missing are the voices of the leadership at the local level who women and reproductive age persons identify as their advocates. For example, on bodies such as the New York City Maternal Morbidity and Mortality Review Committee, how are the voices of the women represented? What is the racial and ethnic composition of the committee? Are there midwives, doulas, community health workers present who represent the geographic corners of the city? Or is the committee composed of individuals who Black women and reproductive age persons report have failed to render respectful care? Unpacking the issue around committee composition is critical because committee composition dictates the discussion, direction, and the recommendations that are put forth. Entities or organizations that have historically opposed policies that support birthing people choices or are not supportive of a shared decision-making model of care should be precluded from participating on the Maternal Morbidity and Review Committee. Black and reproductive age persons want access to midwives. One recommendation from the Maternal Mortality and Review Committee is that midwives must be integrated into obstetrical departments throughout New York City. This recommendation is consistent with research findings that poor coordination of care across providers and birth settings has been associated with adverse maternal newborn outcomes. The integration of midwives into regional health systems is a key determinant of optimal maternal newborn outcomes. And I thank you very much for this opportunity to present my testimony.
Thank you very much. What I'm going to do, in the interest of time, we're going to ask every other panelist that's coming on, there's a 3-minute limit. Please summarize your testimony. You could submit written testimony either today or within, 72 hours, and the staff goes through it completely. So, but thank you very much.
Thank you very much to Councilperson Schulman and Councilperson Narcisse and the Health Committee. My name is Ginger Davis. I am the president of the Sickle Cell Thalassemia Patients Network. I'm also an adult living with sickle cell disease. Listening to all of the testimony today, it's been a lot. I'm happy that the city and state is making an effort to gain more health coordinators to help women during their pregnancies and after their pregnancies. And as Ms. Ryan says, you know, the availability of registered nurses who are midwives is a resource that's underutilized. And usually women who are on Medicaid and Medicaid managed care do not have the opportunity to get these services. We also don't have the opportunity to get fertility services. Right now, for the first time in more than 100 years, there is a tremendous amount of study and development for disease-modifying medications, cell and gene therapies for sickle cell disease, beta thalassemia, and other inherited blood disorders. And some of them that are requiring, particularly the disease-modifying treatments that are cell and gene-based therapies that require chemotherapy. Women with sickle cell disease, von Willebrand's, and hemophilia and thalassemia aren't given the option for fertility services to preserve ovum before they go through a procedure. And that is something that we have been advocating for a long time, for those to change and have the same parity of women with cancer when they're undergoing treatment to preserve their reproductive choices. Also, I want to speak briefly on people with sickle cell trait. The problem of sickle cell disease is not really the disease itself, but the fact that the public does not know about sickle cell trait. They don't know that they carry, they don't know that there's more than one trait, they don't know how it impacts. And there also is very little information about people carrying a trait, a hemoglobin trait, who are impacted and being told that it's everything else but sickle cell. We'd like to see that the same metabolic and genetic panel that happens in newborn screening here in this state also happens for people of childbearing age, starting with teenagers, who unfortunately, you know, there is a lot of teenage pregnancies, and starting from a young age right through to now women are having babies in their 50s, they should be able to have access to these metabolic and genetic screenings so they know before their child is born and the newborn screening panel comes back that they were carriers for a genetic trait that will impact their child. Thank you for allowing me this opportunity to testify.
Thank you so much for your testimony. We'll be moving on to our next public panel. In order, I'll be calling on Charlene McGee, followed by Deidre Sully, followed by Neela Natharanjan. Charlene McGee, you may begin your testimony as soon as you're ready.
Time starts now.
Hello, good afternoon, everyone. My name is Charlene McGee. I am the founder of Nieces Purple Heart Foundation, and I'm going to tell you how Nieces Purple Heart Foundation was founded. Last year, August 28th, my niece Denise Williams went to Queens Hospital seeking help for postpartum depression. She went in the hospital on the 28th of August. She died on August the 30th. As a result, my family's life has changed forever. Denise left behind 2 children, Adelie and Aviana, who I care for every day. And my niece Belinda, she's their caretaker. I became a maternal health advocate, like I said, since last year. I have had the opportunity to work with many doulas within New York City, quite a few midwives, and one of the things that I learned, which the young lady was speaking about, was PMAD, which something which that's what my niece was suffering from, and she shouldn't be dead, period. So what I want to say, and I'm getting a little bit choked up because this is very important for me to speak about this, because I have a daughter who's pregnant right now, and doulas are very important in our communities. My niece did not have, she had health insurance, but it wasn't the health insurance, I guess if you want to call it the good health insurance. So she was just subjected to go to a community hospital. But I'm here today just to basically say it is really, really important for you all to really take a look at the bills that they're presenting today. Because like I said, doulas and midwives are what is needed in the maternal health field. I really do have much more to say, but I know we only have a few minutes. So I'm gonna say thank you again for giving me the opportunity to share just a little tidbit about my niece's story. And if anyone wants to find out any more information about Niece's Purple Heart Foundation, we are on social media. We are welcoming, to work with people, and we are just here to advocate for all of women who do not have voices on their own. Thank you again.
Thank you very much for your testimony. We really appreciate it.
Thank you so much for your testimony. We'll now move on to Deirdre Sully. You may begin as soon as you're ready.
Time starts now.
Good afternoon to the City Council, Committee on Health, and the Committee on Hospitals, and respective Chairs Schulman and Narcisse. Thank you for your time today and your commitment to learning about and addressing maternal health access and equity. We've heard a lot today about maternal health access and equity, so I'll keep it brief. Structural racism is the root cause of disparities in perinatal health and cannot be overlooked. It is known that patients respond better to providers that represent a shared lived experience. Many Black and African American women are denied optimal care because providers fail to impart and engage them with respect and dignity. Furthermore, 75% of pregnancy-related deaths of Black mothers are deemed to be preventable. Building capacity and opportunities to train Black and Indigenous persons of color as healthcare providers within the community is one step to decreasing the implicit bias that results in racial discrimination. Strengthening maternal child health systems of care and individual family health and well-being are powerful drivers of equity. At Public Health Solutions, we are creating partnerships and a technology-driven network between clinical care providers, managed care payers, and community-based organizations, providing maternal child health services to strengthen the system of care and unify access to proven programs that enhance maternal and child health. Research is very clear that increasing access across perinatal continuum to sexual and reproductive health programs, home visiting, and family support services improve health, stability, and outcomes related to the social determinants of health. Because health services are often fragmented and uncoordinated, PHS is working to implement a strong community resource network that connects New Yorkers to home visiting, doula care, breastfeeding support, father support, education on the NYC standards, for safe and respectful care at birth, and resources related to the social determinants of health. Where you live and where you give birth should not dictate whether you live or die. Efforts to advance quality clinical care and anti-bias and discrimination in the hospital setting must be paired with comprehensive community support systems and infrastructure development for us to collectively move the needle on maternal morbidity and mortality. Thank you.
Thank you so much for your testimony. We'll now hear from Neela Natharanjan. You may begin your testimony as soon as you're ready.
Your time starts now.
Good afternoon. My name is Nila Natarajan, and I'm a supervising attorney and policy counsel in the family defense practice of Brooklyn Defender Services. In this role, I also serve on the city's Maternal Mortality and Morbidity Review Committee, as mentioned earlier today. I thank the Committees on Health and Hospitals and Chair Schulman and Narcissi for the opportunity to address the council. Given Brooklyn Defender Services' experience working with thousands of parents and families prosecuted by the city in neglect and abuse proceedings in family court, we are keenly aware of the ways in which inequities in the city's provision of maternal and perinatal health care render Black and Latina parents and families vulnerable to the discriminatory and disproportionate surveillance and punishment of the family regulation system, which you may also know as a child welfare system. Critical for your consideration today is that a primary way that pregnant people, new parents, and newborns come to the attention of family regulation authorities is through prenatal and postpartum care providers. These professionals, entrusted with the care and treatment of our city's birthing people and newborns, are routinely drug testing patients, particularly Black and Latina people and their newborns, without notice and without consent. In our practice, we have rarely, if ever, seen an explanation recorded for why a drug test was deemed medically necessary. And despite the absence of any indicators of harm to a newborn and the additional cost associated with drug testing, hospitals conduct these tests on poor patients and routinely report results to the authorities. This unconsented to practice, often called test and report, much like the practice of stop and frisk, leaves pregnant patients, especially those using public insurance, vulnerable to intrusive government investigations and traumatic family separation, and does nothing to guarantee that patients get the care and support we have discussed in detail today. When pregnant people are tested and reported to authorities, or live in fear of this surveillance, their relationships with medical providers are damaged or severed, and future engagement with vital healthcare drops. This council has the ability to repair some of this harm. Introduction number 1426 was previously introduced by now Borough President Reynoso and requires that medical providers get the informed and voluntary consent of patients before conducting a drug test, just like is required for any other medical procedure. In order to truly address the inequities in maternal well-being that our committees are aiming to eliminate today, this council must enact bold solutions, such as 1426, that ensures healthcare that is non-discriminatory, dignified, and patient-informed. Thank you very much.
Thank you so much for your testimony. I'd like to now just read out the names of some folks who have registered to testify, just to ensure that we didn't miss anyone. We have Gregory Brender, Emily Frankel, Ngozi Moses, Megan Racklin, Eva Kornaka, and Jessica Tang. If anyone is present, you can use the Zoom raise hand function. Okay, that concludes public testimony, so I'll turn it to the chairs.
Okay, I want to thank everyone for the testimony today, and again for the administration. We have a lot of work to do. This is an extremely important topic, and we will continue to work on it. And I want to thank everyone, and I will now hand it over to Chair Narcisse.
I just want to say thank you to everyone, all the advocates that came to testify. We appreciate that. And I have to say again, thank you to Committee Counsel Habani Hahuja, Policy Analyst, and Balkan, as well as my amazing team that always supported me. Busy, Syed, Joseph, Frank, Shay, Kim, Irina, Bonnie, Evans, and Stephanie. So thank you for doing the work that you do for the people of New York City. Thank you.
This committee hearing is now adjourned.